este apnea. Nu știe să facă prea multe. Ce știe să facă cel mai bine este să ne tulbure somnul. Da, poate fi chiar enervantă. Haideți să vă explic ce este apnea de fapt. Apnea în somn este o condiție în care mușchii din spatele și din părțile laterale ale gâtului se relaxează atât de tare încât atunci când dormi, respirația este blocată pentru câteva momente. Când se întâmplă acest lucru, creierul observă o lipsă de oxigen în sânge și ne trezește suficient pentru ca respirația să revină. Apoi intrăm din nou într-un somn adânc, iar ciclul continuă, fără ca noi să observăm această succesiune. Așa cum spuneam, totul se întâmplă în somn. Chiar și sfărăitul poate semnaliza existența apneei. Dacă un copil sau un adult sfărăie mai mult de câteva săptămâni sau luni la rând, înseamnă că nu respiră bine în timpul somnului. Toate acestea pot duce la un nivel scăzut de oxigen în sânge și niveluri ridicate de dioxid de carbon în somn. Pentru a pune în evidență apnea din timpul somnului, se pot realiza analize specifice, numite poligrafie sau polisomnografie. Despre acestea și despre posibilități de tratament vom povesti mai multe în următorul episod al animației. Până atunci, puteți afla mai multe informații pe pagina noastră de Facebook, Asociația pentru tulburările de somn la copii și adolescenți. Împreună putem promova un stil de viață sănătos.
Good morning, everybody. Bună dimineața tuturor. Suntem în a doua zi astăzi. We are on the second day. Yesterday was a full dynamic, very interactive. So today we start our event with a complex subject about complex obstructive sleep apnea. Thank you very much to Professor Stijn Verhulst from Belgium. It is a little bit different time zone between Romania and Belgium, but he is with us now. So I think we can start, and you can put question and send question on Q&A on chat, or if you want to activate your microphone, please do that. So Professor Stijn Verhulst, thank you very much.
Thank you, Michaela. It's always a pleasure to be here. I think that you can see the slides, right?
Yes, it is okay.
Thank you. So I will talk about complex obstructive sleep apnea. I have a few introductory theoretical slides, but I will mainly illustrate my points through several cases. Now, complex OSA is mostly defined as children with underlying conditions with obstructive sleep apnea because their management is more complex. But I've also broadened a little bit the scope of my presentation to illustrate you other types of complex obstructive sleep apnea. For instance, children presenting with both obstructive and central sleep apnea, children presenting with obstructive sleep apnea and hypoventilation, and also very briefly about children who are intolerant to CPAP therapy. Why is this relevant? Because I think almost all, or certainly the majority of these children will also have underlying conditions. So, as I already mentioned, complex OSA is mainly focused on obstructive sleep apnea in children with underlying comorbidities, underlying syndromes. This includes obese children, children with genetic syndromes, craniofacial disorders, neuromuscular disorders, or children with underlying neurological conditions with cerebral palsy. Why are they complex? Because the literature has showed us that they have a high rate of persistent obstructive sleep apnea after the routine first-line therapy, adenotonsillectomy. We have always asked us the question, are these children routine candidates for adenotonsillectomy? And this includes very few slides, theoretical slides, but I feel that this is a very important point to make. I think that we are beyond the point of performing adenotonsillectomy in every child with complex obstructive sleep apnea. And then just see what happens next and see if there's persistent or obstructive sleep apnea and then treat accordingly. I think that this ship has sailed and that it's really important to pinpoint the exact cause of obstructive sleep apnea before any intervention. And this is a paper that I illustrate my points with. This is a paper from our group looking at the effects of adenotonsillectomy in Down syndrome children with obstructive sleep apnea. And as you can see here, there's a clear reduction in the apnea-hypopnea index after adenotonsillectomy. However, it's very important to look at the individual patient data. And as you can see here in yellow or in orange, first important conclusion is that there is a high prevalence of residual or persistent obstructive sleep apnea after adenotonsillectomy. But you certainly have children who respond very well to the surgery and who are certainly candidates for adenotonsillectomy. However, you also have non-responders, children where the apnea-hypopnea index stays the same or even goes up after the surgery. These children, for us, are no candidates for adenotonsillectomy because they also have an increased risk of post-operative complications. So very important, I think that our field is ready to start to individualize treatment, to identify markers that could identify the success of a treatment before the actual intervention. And I think most used technique for that now, and in a lot of centers is already incorporated in the clinical workup, in the routine clinical workup of these patients, is drug-induced sleep endoscopy or DISE. I will show you an example of a DISE in one of our patients performed by my ENT colleague, Anne Boudewijns. You see here, of course, clear adenoid hypertrophy. And then we go down. And then here you see that there's a clear tongue base collapse. So based on this DISE, this child could certainly benefit from adenodectomy. And then afterwards, we would have to see if there's still residual tongue base collapse present. In the case of residual OSA, probably this child will end up with an adenoidectomy and CPAP. So this is the picture of what we call DISE-directed therapy. You see that still a lot of children, this is again in Down syndrome children with obstructive sleep apnea, a majority of these children will still get adenotonsillectomy or tonsillectomy, but you have a lot of other therapies going from medical therapy, Montelukast, to CPAP, to orthodontics, and so on. So DICE-directed therapy really broadens your array of possible therapies in these children. And this is a recent systematic review on the use of DICE in children. And you can see here, I've highlighted it in red, that DICE-directed surgery, it changes the management in about 30% of patients. So this is not a small minority of patients. In 30% of patients, the management is changed by the use of DICE. And the authors conclude that it is especially important in children with complex obstructive sleep apnea, but also as a small note, I think that this is also very important that normal children, children without underlying conditions, are also that we also need more studies investigating the usefulness of DICE in this group. So let's illustrate this with a case. This is my first case. This is a 4-month-old baby with Down syndrome. He has a congenital heart defect and he presents with failure to thrive and chronic noisy breathing and stridor. Of course, we do a full sleep study, polysomnography, which shows a very high obstructive apnea-hypopnea index of almost 60. And of course, with a mean saturation of only 90%, which is severely disturbed. So further management, I think this is a Down syndrome child, 4 months old. We do not expect that adenoids and tonsils play a big role in this child. He has noisy breathing, he has stridor, he has severe obstructive sleep apnea with low saturation. So I think that this is an ideal candidate for upper, but also lower airway endoscopy, bronchoscopy. So this revealed only a laryngomalacia. Is a treatment indicate? Because we know that in some children, laryngomalacia, it tends to improve spontaneously over time. But in this child, I think that urgent treatment is indicated. First of all, he has severe obstructive sleep apnea. He has growth retardation. And as you know, children with Down syndrome have an increased risk of presenting with pulmonary hypertension, combined with the severe obstructive sleep apnea and the low oxygen saturations. This is a child that requires urgent treatment. So what we would do in the clinic is we would first stabilize him on CPAP therapy, and then afterwards he will be referred to our ENT colleagues for a supraglottoplasty, which is a treatment of choice for laryngomalacia. But please note that it is sometimes less efficient in children with underlying conditions. So especially in this child with severe obstructive sleep apnea and Down syndrome, you have to control the sleep study after the supraglottoplasty and to monitor this child for residual OSA and perhaps continue the CPAP treatment. So the management of obstructive sleep apnea in these children with underlying conditions is always multidisciplinary. You certainly need the ENT surgeon, you need a pediatric pulmonologist who is experienced in CPAP and non-invasive ventilation, but you can also need ENT maxillofacial surgery and so on. Let's look at another example of children with complex obstructive sleep apnea, where we have the combination of obstructive with central sleep apnea. This is a full-term infant that was admitted to our neonatology department because of obstructive breathing and dysmorphic features. So again, we did a sleep study, and you see here quite severe obstructive sleep apnea with an index of 46, but also with many central apneas with an index of almost 19. Remember that in children, the cutoff for a central apnea index is approximately 5. So this is clearly elevated. So here we have a case of an infant with obstructive breathing and with a mixed sleep apnea. You see here his saturation profile, so mixed sleep apnea with a lot of desaturations, and as you see here in the hypnogram, with a lot of sleep fragmentation as well. So I think this picture really summarizes that this child is in need for urgent treatment as well. So how would you approach this case? Again, it's mainly obstructive. It's a child with dysmorphic features. So I think, again, you need an upper airway endoscopy. And this shows a general airway hypotonia. So the question then is, this is something that you cannot surgically address. Do you put this child on CPAP, or do you put him on NIV that you can also control the central apneas? We put the child on CPAP therapy first. This is something that we are sometimes obliged to do in Belgium because of reimbursement criteria, but here it was also a hypothesis, because we hypothesized that it was mainly the obstructive apneas that caused the disturbed breathing in this child. And you see here, with a relatively low pressure of 5 centimeters water, you completely abolish the obstructive apneas and hypopneas. And because you improve this obstructive breathing pattern, you also get a significant decrease in the central apneas. And this is sometimes a little bit complex. In children with mixed sleep apnea, as in this infant, we had a predominant obstructive abnormality, and we know that CPAP will improve both the obstructive and the central component, because the central apneas in these patients are a consequence of an irregular obstructive breathing pattern. On the other hand, if you have a predominant central abnormality, when you put these children on CPAP, the obstructive events will change into more central events, and this is an indication for further investigations and probably non-invasive ventilation. And I will illustrate this with 2 other cases. This is a 9-year-old boy who was referred to us after a brain tumor located at the fossa posterior, for which he received repeated surgery, chemotherapy, and radiotherapy. This is an extract from his sleep study, and you can see here a lot of obstructive events. But they also have this type of periodic breathing pattern. But in periodic breathing, we expect central apneas, but in this case, we have obstructive events. But here, this is a case with a brain tumor located at the brain center for the control of breathing. So here, we mainly expect a central abnormality. This is a sleep study, so again, very high obstructive index with some lower number of central apneas. And as you see here, a very low mean saturation during sleep. So in management, if we put this child on CPAP first, but then we only saw that all obstructive events, they all changed into central apneas. So here we switched to non-invasive ventilation with a backup frequency, the ST mode, to also correct for the central apneas. And then finally, a very short case, an 8-year-old boy who was referring to us for snoring, witnessed apneas, and also a headache. And here you can see a clear pattern of periodic breathing, a lot of central apneas with an index of 111, and 35% of his sleep time was spent in periodic breathing. This is a complete central apnea phenomenon. And of course, this child can need a lot of investigations, but the most important is a brain MRI to look for central abnormalities. And this child had the classical Arnold-Chiari malformation, which you know is associated with central apneas, and he will need neurosurgery. But these cases, they illustrate the combination between obstructive and central apneas, and that the therapy is not always straightforward. One small paper from us, also in normal children with obstructive sleep apnea, you can have an elevated central apnea index. This is data from 90 children, normal children, no underlying conditions, showing that the majority of these children with obstructive sleep apnea will have some central apneas. The most of all will be the index between 1 and 5, and a minority of these subjects will also have central sleep apnea, defined as a central apnea index of 5 or higher. But in these children, you can await the upper airway surgery, because after adenotonsillectomy, and that is here depicted in light gray, the central apnea index will significantly decrease. And we didn't have any child after adenotonsillectomy still with persistent central sleep apnea. So I think this is also an important message. If you have a normal child with obstructive sleep apnea, but with some central apneas, you can wait the sleep study of the control sleep study after adenotonsillectomy, and the majority of these children will have no central apneas after the correction of their obstructive sleep apnea. Some cases about the combination between obstructive sleep apnea and hypoventilation. This is a first case, a girl of 13-year-old with morbid obesity who was referred to our sleep lab because of the obesity, the snoring, but also because of excessive daytime sleepiness, frequent nighttime awakenings, and still she had nocturnal enuresis, which can also be associated with obstructive sleep apnea. She was morbidly obese, illustrated by the BMI of 36, but she also had a progressive scoliosis with a restrictive lung function pattern, as you can see here, with a vital capacity of around 60%. She had, again, very severe obstructive sleep apnea. You can see that here, an obstructive apnea-hypopnea index of 130. Very high sleep fragmentation with an arousal index of 76. Only 4% of her sleep time she was spent in REM sleep, 11% in slow wave sleep. So these two figures, the arousal index and the abnormal sleep architecture, they really explain the excessive daytime sleepiness. She also had hypoventilation. Oxygen saturation was only 82%, and she had daytime and nighttime hypercapnia. So this is a patient where we would really start non-invasive ventilation because of the obstructive sleep apnea, because of the restrictive lung function that was caused by the scoliosis, and this corrected the obstructive sleep apnea and the saturation and the hypercapnia. We stabilized this patient, and then she was sent to the orthopedic surgeon for scoliosis surgery, which corrected the restrictive lung function. And after the scoliosis surgery, she could be weaned from non-invasive ventilation to CPAP therapy, because then she only had obstructive sleep apnea without the hypoventilation. Another case to show you that it's not always straightforward. This was a girl from 18 years old, and she presented to our department very late with a late diagnosis of mucopolysaccharidosis type 6. We did a sleep study, and again, you can see here very severe obstructive sleep apnea with an index of over 100. And again, with a low mean oxygen saturation of, let's say, 88%. She had a blood gas in the evening before the sleep study that was normal, but in the morning she was clearly hypercapnic with a CO2 of 73%. Further workup, and I apologize because this is in Dutch, also included a spirometry. And again, you see here that she's also quite restrictive with a vital capacity of 44%. So the management of this patient, again, severe obstructive sleep apnea, restrictive lung function, morning hypercapnia, but no daytime hypercapnia. I think that the majority of us would start non-invasive ventilation in these patients. Again, at the time in Belgium, we had to start the patient on CPAP therapy. We had to increase the pressures quite a lot to 10 centimeters of water. This completely improved the nocturnal breathing. She had an apnea-hypopnea index of 5 under CPAP. Mean oxygen saturation was 96%, but she was also completely normal capnic during the day. So this also corrected the hypoventilation. So this patient had mainly a severe obstructive sleep apnea with obstructive hypoventilation rather than, let's say, total hypoventilation. But probably, I think the majority of us would consider that non-invasive ventilation would be the most correct option. This was also done several months after this sleep study because the patient had difficulties with tolerating this high CPAP pressure. So we put her on non-invasive ventilation, which was better tolerated. And this brings us with the last part of my presentation that will deal with CPAP intolerance. A lot of the patients with complex obstructive sleep apnea, they will end up with CPAP therapy because they're either no candidates for upper airway surgery, or because it's, for instance, unethical to perform tracheostomy, and then you end up with CPAP in the end. This means that these patients, they are really depending on their CPAP therapy. And in some of these patients, because of neurodevelopmental delay or because of behavioral difficulties, CPAP in some of these patients can really be a challenge. And what to do if CPAP is the only option and you want to avoid a tracheostomy, for instance. In these children, we and other groups as well, had quite good experience with the OptiFlow, the high flow nasal cannula, as an interface for chronic CPAP use in children. You all know that the high flow nasal cannula of the OptiFlow is a broadly used therapy, for instance, in children with acute respiratory distress, like in cases of bronchiolitis, but it also can treat children with obstructive sleep apnea. You can either give the OptiFlow device to the patient's home. We have created the system where you can couple the OptiFlow interface, so only the high flow nasal cannula, to a regular CPAP device, which has some advantages, as we will discuss later. The exact setup is discussed in this paper from our group from several years ago. It helps. It really helps, but you cannot expect high pressures from this OptiFlow device. We didn't measure it, but probably you can give 3 or 4 centimeters of water. So in children who need really high CPAP pressures, the OptiFlow interface will not be able to deliver this high pressure. But as you can see here, in a number of children that we treated with the OptiFlow interface, you can see that there is a really good decrease in the apnea-hypopnea index. In some children, of course, they still have persistent obstructive sleep apnea, but as you can see here, when you go from 100 to 6 or 7, we are really happy with that progress. What are the practical advantages of the OptiFlow interface coupled to a regular CPAP device? The main advantages is that you can use alarms and that you can use a battery. And this is something that is not possible with the regular OptiFlow device. You have to know that the leak can be very low, so you have to disconnect the low leak alarm. Otherwise, you will have complaints by parents because they have continuous alarms during the night. We mainly use the cannula based on the manufacturer's recommendations, so according to the age of the patient. But a lot of centers will use the largest possible cannula to really maximize the amount of pressure that you can deliver through this interface. And the majority of centers that are using Optiflow in children with CPAP intolerance really have excellent compliance with this device. So it's really an option for children who are intolerant with a regular nasal or oronasal mask. Because of the low pressures and because it's the cannula is too small to really sense the patient's effort, it is not suitable for bi-level ventilation. So this interface is only possible for children who need CPAP therapy. It's not suitable for non-invasive ventilation. And I think that I stayed within my time. I would thank you for your attention, and I'm happy to take questions.
Thank you very much. We don't have so much experience with this Optiflow, so to use it in children who need CPAP. So how do you, if you can just detail a little bit, how do we think, how do we decide, is there any risk?
There is, we always start with the regular CPAP masks, the nasal mask or a nasal mask, because they're more effective. And they're more effective. They will certainly control the obstructive sleep apnea. But if we notice that the child is intolerant for CPAP, and we do our best with education, or we admitted the child to our service, and the child really doesn't tolerate the mask, then it has become our first line rescue therapy, because we know that although it may not be perfect, it really improves the obstructive sleep apnea, and almost all patients will really tolerate the Optiflow interface, and it's completely safe to use.
Is there any way to establish like a titration, or you know, when we do manual titration, how do you start actually how do you make the settings?
With the Optiflow or with the CPAP?
With the Optiflow.
Well, as you can, I don't know if you saw it on the slide, but we had some patients on the Optiflow ranging from 4 to 7 centimeters of water. So you can of course increase the pressure, but we do not know if it really is representative for the pressure that the patient receives. But probably, yeah, it will blow a little bit harder. So there will be a slight increase in the pressure. And we titrate it the same as we do in CPAP on a regular mask. So also a manual titration in the sleep lab during polysomnography. We have the same protocol, but we know that probably when you put a CPAP pressure of 7 or 8, that it's in real life that it will not reach 7 or 8 in the patient. So when the patient does not tolerate a nasal mask, you have Optiflow, but you need a high pressure, then you have to make a balance and see the balance between the patient tolerates it and I have an improvement in my obstructive sleep apnea, although it may not be perfect.
Mm-hmm. And if you cannot, let's say we cannot perform a manual titration with the polysomnography, meaning CPAP now, but also you said it's also the same in Optiflow. But let's talk about CPAP. How can we, let's say, titrate a patient if we do not perform a manual titration with polysomnography? Or maybe from your experience, yes. Mm-hmm.
Well, I think very important, and I always put the emphasis that on my colleagues and our fellows, is that it's very important to do a clinical titration as well. You can do a lot in the clinic standing next to your patient, see if the patient snores, has an obstructive breathing pattern. And that's also very important that when you notice that you increase the pressure. I think purely for children with obstructive sleep apnea, that's something that we also do, is that you can titrate just by oximetry. Oximetry together with a clinical titration is certainly very, very valuable. And we know that hypoxia, intermittent hypoxia, desaturations are the main consequence of obstructive sleep apnea. So if you don't have snoring anymore, if you have a regular breathing pattern, and if you have a normal oximetry, then I think that this can certainly replace a full polysomnography.
Mm-hmm. You said about central sleep apnea, and they can correct with a CPAP in obstructive. So there are two questions here. Let's say, what's the mechanism? We have also so many central apnea in a patient with obstructive sleep apnea, and probably this is the reason that the CPAP correct them. And if there is a risk after a while, there is also a question in chat, if there is a risk after a while to reappear this central apnea.
Yes, it can be quite complex, but the case that I presented, it was an infant, and we all know that infants can have a lot of central apneas because of immaturity of the control of breathing. And we all know that if you have an irregular breathing pattern, that this can provoke central apneas. And this was also the case in this child. You have a lot of obstructive events. Obstructive events will lead to arousal, can lead to somewhat tachypnea, irregular breathing pattern, and this can cause a drop in CO2, which can then provoke a central apneas. So if you then control this obstructive breathing pattern, then you will not have this aggravated response by the arousals and the hyperventilation and so on. And then you see that there's a positive effect of the central apneas. This is also the same mechanism by how oxygen can improve central apneas in children with only central sleep apnea. Because you have a central apnea, you have a desaturation, and then you have an arousal with an aggravated response, and this causes another central apnea. But if you abolish the desaturation by giving oxygen, you do not get this abnormal response, and you stabilize your breathing pattern. So this was the case also in our infants. I think, of course, we all know that this has been shown in children, adolescents, and adults, that sometimes that's a physiological reflex, that you have an obstructive sleep apnea patient, that you give CPAP, you increase the pressures, and then you see central apneas appearing. This is a normal physiological response. And in these patients, it's safer to again lower the pressure and just wait and see and repeat the titration after several weeks. And then in the majority of the patients, the central apneas will have disappeared. If you're not sure, like in our case, we were absolutely sure that this was purely obstructive and that central apneas will not reappear after time. And you can check that again with a controlled sleep study or a polygraphy or an oximetry. But if you are not sure of, is this purely obstructive or is this a kind of mixed phenomenon, and I'm a little bit concerned that central apneas will reappear, then I would suggest that you would do a control polygraphy, for instance, after a few weeks or 2-3 months of CPAP therapy. I absolutely agree with this point. It's a little bit of a gray area, so it's difficult to give a black and white answer. But I think if you're not sure, if you really think that there's a central component, then I think it's very important in children to repeat the study after a few months.
Yes. Also, if you understand the physiopathology in different situations, maybe this is the reason. Then, and also you present a case with I think the case 3 with Arnold Chiari. Sometimes they also have obstructive and central, and no, and it's very useful, the CPAP.
Well, if you have a case where you diagnose them with, let's say, sleep disordered breathing with Arnold-Chiari malformation, especially when it's really severely abnormal, the anesthesiologist and the neurosurgeon, they will not operate before the child is put on ventilation therapy. But I think Arnold-Chiari, also if it's mainly obstructive, you should put him on non-invasive ventilation. Because it's a problem of the control of breathing. So you will always have a mixed component, and CPAP, I do not believe that it's safe to put them only on CPAP, and I would immediately start with non-invasive ventilation, that you really have the backup frequency available.
Yeah, so the backup rate, yes, just to be sure.
Yes.
And after the surgery, if the surgeon, when decides to do the surgery, after how much time, let's say approximately, should we reevaluate for the breathing, sleep disorders breathing?
I'm not sure if there are recommendations for that, but I would say around 2 months after the surgery, to see if it's...
And in this time, the child will be on the ventilator, of course, or after this.
Not always. I can remember some children where they are in the hospital for a few days after the surgery. If they have a normal saturation profile after the surgery during sleep, I think that you can be relatively that it's relatively safe to stop the non-invasive ventilation. And I think that you are more worried, like in our case. He was already, I do not remember by heart, but I think he was 8 or 9 years old. So probably the Chiari malformation was there for a long time. And we know that if the abnormalities, if the Chiari malformation has been there for several years, they are somewhat at risk that surgery does not resolve everything. So I think especially these children, you need to follow up a little bit more closely.
And there is another, so see, I don't have notes, but I have many questions after your presentations. There is another category you touch a little bit with hypoventilation only, and there is also this patient. There are these patients with thoracic insufficiency, with genetic syndrome like Marfan or Ehlers-Danlos, maybe diagnosed or not yet, but still they have very important thoracic abnormalities. And also on a sleep study, they don't have usually too many apneas, but they have a CO2 elevated, let's say more than 50. In this case, so these patients have 15, 16 years old, are like this. Should we start the ventilation before the surgery? Maybe they want surgery, maybe they don't, maybe the surgeon decide to do it. But if it's chronicle, evolution in this patient, should we, if we notice this hypoventilation at 16 years old, what is your opinion?
I must say that I do not have any Marfan or Ehlers-Danlos patients on non-invasive ventilation. Do you mean that they have thoracic abnormalities, or?
Yes, it's a very important pectus excavatum and very shallow, narrow thorax.
Okay.
And on spirometry, the FVC is around 50 or 60.
Okay.
But otherwise they are well. Maybe they are a little bit tired. They don't do so much effort. And also the CO2, it's not very much elevated. Let's say around 50.
And do they have a lot of desaturations as well?
No.
Oh, okay.
No.
So I think that we all have this type of patients with some underlying conditions where you screen them with a study because that's
Yeah.
recommended, and then you have this mildly elevated CO2, and the patients sometimes they have some symptoms and some otherwise they do not have.
Sure.
I think it really depends on the motivation and on the symptom burden of the patients. We all have patients where we say, okay, let's try non-invasive ventilation, see if you sleep better, that you can concentrate better at school, that you're feeling less tired. Sometimes they tolerate it excellent, but sometimes they don't want to use the machine as well. So I think especially in with they have a will of their own. So I think it's really important to do a joint management with the patient, with the parents, and to see if they are motivated to try. I think in my experience, when they experience the real benefits of the therapy, they will use it. If they don't, then it can be very difficult.
The recommendation for the CO2 are, let's say, very dynamic. There were that level of CO2 to start the ventilation above the 50, then it is above 45. How are now the recommendation for hypoventilation?
Well, it's indeed a difficult topic. We have a task force, but I'm trying to find the table real quick. We have a task force now in the European Respiratory Society about non-invasive ventilation in children, and we are almost ready to submit the final manuscript. But I cannot find the table directly. So perhaps if you agree, Mihaela, that I look for it after the presentation and I mail it to you, and then you can distribute it, because I think we made a good recommendation that is, I think, clinically feasible, clinically important, and clinically relevant as well.
This will be very helpful, and when the document will be in place, we will share it also from European Respiratory Society. It's very helpful. They are very helpful because the cutoff is changing. The patients are different, and sometimes it's we want to start a ventilation even if the CO2 is not too elevated, but you think maybe it's good to start it, maybe it's not. Yeah. Mm-hmm. Well, I think we can discuss and a lot of details in this patients, but maybe it's time to move forward with the presentations. There is another questions from my colleagues, but maybe if okay. Okay. Thank you again, Professor Steenfrohus, for being with us today. Thank you very much.
Thank you.
O să continuăm și domnul profesor făcea atingere la finalul prezentării dânsului de informații legate de complianță la CPAP, la terapia CPAP, astfel încât cumva un firesc devine a continua cu prezentarea doamnei doctor Lucica Barangă, abordarea practică în aclimatizarea și inițierea terapiei SIPAP-BIPAP la copii. Cred că trebuie să dai share screen și să deschizi microfonul.
Da, încerc să dau share screen, dar nu știu de ce nu se vede.
Da, este în regulă.
Mulțumesc.
Slideshow, vă rog.
E o mică întârziere cu laptopul meu. Bună dimineața! Da, foarte elaborată și complexă prezentarea domnului profesor. Mie mi-a rămurit foarte multe lucruri, întrebări înainte să le întreb. Numele meu este Lucica Barangă, fac parte din colectivul condus de doamna doctor Oros în clinica de somnologie din Ponderas Academic Hospital. Și astăzi vreau să vă prezentăm, efectiv, practic, cum abordăm noi aclimatizarea și inițierea terapiei SIPAP sau BIPAP, în funcție de caz, la copii. În general, ne uităm la niște etape și încercăm să le urmărim pentru fiecare copil, chiar dacă în esență se personalizează pentru fiecare copil și se individualizează abordarea. De la început explicăm destul de detaliat, efectiv, ce înseamnă terapia. Se explică terapia, se explică aparatul, se explică tipul de mască, se explică inclusiv cum se monitorizează ulterior, se arată ce trebuie se vorbește inclusiv de ce are de făcut copilul acasă, cum se întreține aparatura și se răspunde pe parcurs, ori la final, ori în timp ce detaliem aceste lucruri și la întrebările părinților, iar în cazul copiilor mai mari, inclusiv la întrebările lor. Și se verifică pe mai multe etape ce s-a înțeles din ce se explică. Pentru că este foarte important ca pacientul să plece acasă cu o idee destul de corectă despre ce vorbim. Întotdeauna ne uităm cu cine vorbim. Așa cum a prezentat și cazul de mai devreme domnul profesor, sunt copii care au deja o poză de fond.
Da, o să întreb și dacă există posibilitatea ca să se achite la fața
Îmi cer
locului
scuze, Mădălina, te rog frumos să închideți microfonul.
Okay.
Așa este online ca și în sală. Ne uităm că acești copii au deja în spate un background, au boli neuromusculare, au deja diverse afecțiuni genetice, cum se vorbea mai devreme, diagnosticate sau nu, dar la care se identifică la un moment dat și prezența unei apnei. Și atunci tratamentul pe care îl introducem acum nu presupune cu ceva ce sunt deja familiarizați, nu presupune nici măcar nu e înghițirea unei pilule, nici măcar altcineva să-i facă un gest medical asupra lor, este ceva ce trebuie învățat și efectuat acasă seară de seară. Efectiv, se explică ce, după caz, aparat SIPAP sau BIPAP, se explică ce este și cu diverse analogii se dorește ca, în final, părintele și copilul să înțeleagă că acesta este un tip de atelă pneumatică ce împiedică colaborarea căilor aeriene în timpul somnului. În deschiderea acestei sesiuni a fost făcută o prezentare, un filmuleț în care se explică foarte plastic și foarte bine din punct de vedere imagistic, efectiv ce înseamnă colaborarea căilor aeriene. Și este foarte important să înțeleagă exact ce se întâmplă, pentru că dacă au așteptări diferite, ulterior o să avem și complianță scăzută la tratament. Aparatul în sine livrează aceeași presiune pe timpul întregului ciclu respirator, atât în inspir cât și în expir, iar în acest caz pacientul este cel care inițiază și inspirul, inițiază expirul și stabilește numărul de respirații pe minut. Aparatul de BIPAP îl folosim mai mult cum s-a zis și mai devreme, în apnei complexe, în care avem suprapunere de apnei de tip central sau hipoventilație, care ne aduc în plus un număr setat de respirații minim pe minut. Astfel încât dacă pacientul nu poate să livreze sau în cadrul hipoventilației scade nivelul de CO2, scade impulsul central, trebuie să avem undeva un background astfel încât să asigurăm copilului un număr de respirații pe minut garantat pe noapte. De asemenea, îl mai folosim în cazurile în care, strict pentru apnei, sindrom de apnee obstructivă, dacă nivelul de presiuni este mai mare și pacientul nu tolerează, se trece pe un aparat de BiPAP, deoarece presiunea de expir mai mică față de timpul inspirului asigură o tolerabilitate mai bună. Vorbim despre beneficii și de complicații combinate, astfel încât pacientul să nu fie copleșit de niciun tip de informație. Cum am zis inițial, este foarte important ca pacientul să înțeleagă exact ce face aparatul și ce nu face aparatul respectiv. În unele cazuri corectează total sindromul de apnee somnică, că se elimină sfărăitul complet sau ce altă problemă este. În unele situații însă nu se reușește decât o ameliorare a evenimentelor respiratorii, deoarece sunt probleme complexe sau trebuie așteptat o perioadă de timp ca organismul să se adapteze la acest tip de terapie. Ce văd foarte evident părinții și ne și descriu când revin ulterior la monitorizare este că cu această terapie copilul este ziua mult mai alert și se poate concentra mai ușor la ce are de făcut pentru școală, astfel încât scade nivelul de agitație, nu mai sunt așa de ranchinoși. Părintele poate să comunice mai bine cu el și astfel copilul își poate îndeplini sarcinile zilnice mult mai ușor, de concentrare la școală, de efectuarea temelor, de kinetoterapie și alte terapii mai au de făcut în timpul zilei. Și foarte clar le spunem de la început că ne așteptăm să se îmbunătățească statusul nutrițional. În cazul copiilor care fac un efort respirator crescut în timpul somnului, bolile neuromusculare, apare o îmbunătățire, iau în greutate, le crește capacitatea de forța musculară. În obezitate se întâmplă invers, pentru că am văzut ieri că din cauza apneilor apar un tulburare în secrețiile de leptină, de grelină, de cortizon. Odată ce introducem terapia, aceste mecanisme sunt reglate și atunci greutatea începe să-și găsească un echilibru. În momentul în care vorbim despre toate aceste beneficii, le spunem și cum trebuie să folosească aparatul. Pentru că, deși într-adevăr pot să existe complicații la această terapie, ei văd că aceste lucruri pe care probabil unul le citesc și dinainte din presa medicală, noi efectiv din momentul în care inițiem terapia facem diverse gesturi astfel încât ele să fie îndepărtate sau minimizate. De la început folosim umidificator, astfel încât să evităm uscăciunea mucoaselor nazale și bucale, unde se folosește și decongestionante nazale, dacă e nevoie. Alegem cu grijă tipul de mască, astfel încât să avem o presiune mică pe punctele de presiune de la nivelul feței, să evităm leziunile de presiune. Ne uităm inclusiv la faptul dacă tolerează efectiv textura măștii. Sunt atât de multe tipuri și deși ele sunt făcute să fie hipoalergenice, fiecare reacție este individuală. Tipul de mască este important inclusiv să putem să evităm licurile, scurgerile de aer de pe lângă mască care pot să dea iritații oculare și se insistă foarte mult atât pe instrucțiunile producătorului de cum se întreține aparatura, cât se vede efectiv de cum inițiem noi, că avem aparatură sterilă care se curăță de fiecare dată, pentru că este important nu ca noi să prevenim infecțiile intraspitalicești, cât și acasă se întâmplă același lucru. Se insistă foarte mult asupra întreținerii aparaturii medicale. Aclimatizarea în sine la terapie însă poate să debuteze mult înainte în momentul inițierii efective, deoarece sunt boli cronice la care se știe deja evoluția naturală, chiar dacă au intervenit mai nou terapii genetice sau tot felul de terapii inovatoare. Acești pacienți, mulți dintre ei, mă refer la cei cu apnei complexe și care au nevoie de termen lung de terapie, au deja grupuri de suport și se informează între ei, știu unde, ce trebuie că se poate întâmpla, știu ce beneficii au, știu inclusiv ce impedimente sunt de la aceste terapii. Și astfel, ei sunt deja undeva în spate informați. Clar că sunt informați și de către medicul curant. Unii dintre ei folosesc deja aparate de tip CAFASI sau Mechanical Exsufflation Insufflation și au deja această obișnuință a livrării unei presiuni prin interfața unei măști. De multe ori, întrebările părinților nu sunt strict, sau ale copiilor nu sunt strict legate de terapie în sine, cum funcționează, ce face, ce se întâmplă. Sunt întrebări conexe în care implică foarte multă emoție. Ei trebuie să știe, vor să știe de ce un alt copil poate are altă șansă, de ce are aceeași vârstă și aceeași afecțiune și încă nu a folosit acest aparat. Mai ales dacă se întâmplă să fie o indicație în preajma unui act terapeutic, o terapie nouă introdusă, o operație, o intervenție chirurgicală. Sunt foarte multe întrebări legate de aceste terapii conexe, nu neapărat de terapia în sine cu SIPA, BIPA. Și întotdeauna răspunsurile sunt personalizate. Pe ce insistăm noi foarte mult este ca aceeași comunicare să fie din partea fiecărui membru al echipei, astfel încât aceeași informație să o primească și de la somnolog, și de la pediatru, și de la ateist, și de la neurolog sau de la chirurg, de chirurgie toracică sau ortoped, sau indiferent de unde primește informația, ea trebuie să fie unitară, astfel încât pacientul să nu fie bulversat de noțiuni diferite. Așa am făcut și în cazul unui băiețel de 11 ani, care era de curând diagnosticat și genetic cu sindrom Prader-Willi și cu obezitate, și la care se dorea inițierea de terapie cu hormon somatotrop. Preinițierea a fost direcționat către clinica noastră pentru monitorizare polisomnografică și a fost diagnosticat cu sindrom de apnee somn de tip mixt, formă severă, deoarece la finalul înregistrării avea un IAH mare de 26,3, mult agravat în timpul somnului REM de 43,5 și pe hipnogramă se vede cum se aglomerează evenimentele respiratorii în prezența somnului REM, cu desaturări destul de importante. Dar aceste desaturări nu sunt strict în somnul REM. Pe hipnograma de jos este un stadiu 2 în care sunt prezente, este hipopnee, după hipopnee cu desaturare, după desaturare se ajunge la valori de sub 90%, iar valoarea minimă, 74%, a fost atinsă la el în timpul somnului REM. S-a recomandat inițiere de terapie CPAP sau BIPAP, în funcție de cum tolerează presiunile, cu titrare manuală a presiunilor. Copilul era în aceeași localitate cu centrul și s-a stabilit că vom face o întâlnire cu mama pentru a stabili etapele ulterioare. Contextul în care a fost foarte important. Era o mamă foarte determinată să facă tot ce trebuie, astfel încât copilul ei să obțină terapia cu hormon de creștere. Copilul avea o mare încredere în mamă, pe care noi am remarcat-o în ziua de diagnostic, și în familie mai era un cadru medical care se interesase înainte, citise, se informase și informase inclusiv pe mamă și pe copil legat de această terapie. Deci, oarecum, fusesem ajutați înainte de inițiere de aceste lucruri. S-a stabilit cu mama, într-o întâlnire separată de momentul de diagnostic, s-a stabilit cu mama planul de explicare și de aclimatizare treptată a măștii. S-a făcut instruirea legată de faptul că trebuie să fie un moment înainte de culcare, la distanță de masă, cum trebuie să au fost foarte multe lucruri discutate cu mama. Mama deja își făcea planul și din timpul acestei discuții știa ce are de făcut pentru ca acest copil să accepte terapia. Tot atunci s-a exersat de către mamă manevrarea măștii. Avem un bust pe care părinții pot să execute fără teamă că vor face ceva greșit. Și când mama s-a simțit în siguranță, atunci a putut să meargă acasă și să pună în aplicare planul de aclimatizare începând de la domiciliu. S-a ținut legătura cu mămica și pentru a vedea cum decurge acest plan și după 3 săptămâni s-a făcut titrarea manuală SIPA, când s-au probat și alte tipuri de măști decât cea pe care o pusese la domiciliul. Și foarte important era, copilul fiind mai mare de 11 ani, copilul a fost implicat în alegerea și montarea măștii. Efectiv, la un moment dat ajungea, vreau eu să fac. A fost ceva nemaipomenit, pentru că era deja obișnuit cu montarea, cu hamurile, ce are de făcut. S-a făcut acomodarea la presiunea SIPAP-ului în stare de veche. Noi insistăm pentru aceste lucruri, deoarece în momentul în care copilul are deja masca la domiciliu, nu mai are surpriza că există ceva atașat pe fața lui. Și în momentul în care știe că această presiune a trăit-o și în timpul zilei, chiar dacă se trezește pe timpul nopții cu presiuni clar mult mai mari decât cele în stare de veche, nu este ceva nou, nu este ceva surpriză în timpul nopții și atunci acceptarea este mult mai bună. Și clar, mama a fost un partener foarte important în tot acest demers. S-a văzut asta și în complianța pe care am văzut în studierea cadrului de complianță de la o lună. Atunci fusese o convenție cu el că o să folosească 6 zile din 7. Odată era plecat de acasă. Folosea între 7 și 9 ore pe noapte aparatul, ceea ce este foarte bine. Deși mai avea un indice rezidual absolut semnificativ față de cel de la nivelul diagnosticului, între timp învățase și altcineva, alt membru al familiei, să folosească aparatul. Era important deoarece mama lucra în ture de noapte. Și s-a putut iniția terapia cu hormon somatotrop. Ceea ce ne-a bucurat a fost faptul că la o presiune rezonabilă de 8 cm, aceste evenimente s-au remis și copilul a fost de acord cu terapia. Altă abordare a fost făcută în cadrul unei fetițe de 4 ani, care era diagnosticată cu atrofie musculară spinală de tip 2 și care avea de asemenea și hipotrofie staturoponderală și scolioză, și care la polisomografia periodică, deși nu avea un IAH foarte mare, avea 1,9 la finalul înregistrării, se vede că deja în somnul REM, somnul profund, nu mai putea să compenseze respirator acest efort, avea un index de 11,1 și deși ea menținea saturații bune, 97%, și saturația minimă n-a scăzut sub 90%, toate aceste lucruri erau cu prețul unui efort respirator și cardiac destul de mare. Frecvența cardiacă și respiratorie este mare pentru vârstă, mai ales că este în timpul somnului. Și de asemenea prezenta constant niveluri ale bioxidului de carbon. Noi îl monitorizăm transcutanat peste 45 de milimetri. S-a făcut această evaluare a fost făcută și prin comparație cu o investigație făcută anterior cu 1 an jumate, aproape 2 ani, și astfel s-a decis că copilul prezintă, de fapt, apnee în somn, chiar dacă este o formă ușoară, medie, și hipoventilație în timpul somnului. Anterior, deși avea la vârsta de 2 ani, 4-2 ani e un pic mai tricky cu cifrele, nivelul de bioxid de carbon, deși avea și atunci frecvențe respiratorie mare, putea să fie menținut la valori normale. Astfel s-a decis că copilul necesită inițiere în terapie BiPAP deoarece părinții erau la distanță de centru, s-a decis că aclimatizarea va fi făcută în ziua titrării. Astfel s-a venit cu câteva ore înaintea investigației în sine și în timp în care copilul s-a obișnuit cu personalul medical, s-a obișnuit cu aparatura, s-a obișnuit cu camera, s-a obișnuit cu ce jucărie am mai adus noi ca să ne ajute la inițierea măștii. Copilul a fost la fel implicat în alegerea măștii. A fost ajutat să pună masca la o jucărie, de altfel nu doar jucăria asta cu măști și copilul pe față atunci, dar pentru copii facem destul de multe jumbușlucuri astfel încât să avem această acceptabilitate. În cazul respectiv, însă, am avut foarte mare atenție inclusiv la emoțiile mamei, care era Mama ne și spusese că era epuizată după ce făcea foarte multe terapii cu copilul, iar copilul, de fiecare dată când vrea să inițieze ceva, avea nevoie de mamă, care era de asemenea speriată. Dar cu răbdare, cu empatie, cu înțelegere, atât pentru mamă cât și pentru copil, s-a reușit. Montarea măștii s-a reușit, aclimatizarea inclusiv a unei presiuni pe timpul zilei și s-a inițiat investigația pe timpul nopții, unde copilul a avut o toleranță foarte bună la mască. Iar a doua zi, când mama a văzut că are un copil cu un somn care a fost liniștit, în care e luminos, care râde de la trezire, în acel moment mama a putut să fie mult mai receptivă la toate lucrurile pe care le-am zis până atunci și atunci, în acel moment, am putut să reluăm cu mai mult succes toate demersurile în care am vorbit ce se întâmplă cu masca. Mama a putut, în sfârșit, să facă efectiv toți pașii pe care, de altfel, trebuia să-i facă și la domiciliu. În concluzie, de ce insistăm foarte mult pe eficiența în aclimatizare și inițierea terapiei? Pentru că ne dorim nu doar un moment singular, ci ne dorim o complianță pe termen lung pentru acești copii. Și în toate aceste lucruri contează foarte mult comunicarea. Comunicarea atât între membrii echipei, cât și ca nucleu, între echipă și nucleul acesta părinte-copil. Informările trebuie să fie detaliate, cu înțelegere pentru emoția celui din față, cu empatie, cu tot ce trebuie încât astfel informația să fie percepută, cu analogii diverse. Și întotdeauna este adaptată pentru vârstă, pentru afecțiune, pentru statusul emoțional al familiei, uneori inclusiv pentru statusul financiar al familiei. Deci să avem în vedere și aceste lucruri. Și foarte important este ca inițierea să se facă în prezența părintelui care a participat la aclimatizare. Dacă, de exemplu, la băiețel am fi vorbit cu mama și venea tatăl la investigație, era posibil să nu avem același succes. Și din cauza aceasta, noi insistăm sunt etape simple, dar insistăm pe ele pentru că astfel avem o complianță pe termen lung și acordăm întotdeauna timp pentru alegerea unei măști potrivite, chiar dacă durează, chiar dacă la un moment dat ne întoarcem la o mască pe care inițial copilul a refuzat-o. Nu contează, contează să avem succes în acceptarea măștii. Folosim de la început umidificatori sau decongestionante nazale și post-investigație menținem contactul cu familia. Au nevoie de încurajare, au nevoie de confirmări până la evaluarea efectiv în clinică. Și de asemenea, aderarea la grupurile de suport ajută foarte mult efortul medical. Cam așa procedăm noi în clinică și vă mulțumesc pentru atenția acordată.
Mulțumim foarte mult. Într-adevăr, este un efort inițierea unei terapii de genul acesta la vârsta pediatrică, dar nu numai, și pentru adulți. O să trecem direct la, după ce am ales masca și am aclimatizat, after we choose the mask, Ivana, now our colleagues present all the effort clinicians do to choose the mask, to make the acclimatization. But now we need also to choose the device and to set the ventilators. So I invite Ivana Shundov from Philips to tell us in details how do we select the device and set the ventilation parameters based on patient type. Mulțumesc încă o dată companiei Philips pentru suport. Thank you again, Philips company, for all support. And Ivana, please share with us.
Thank you very much for the nice introduction. It's a pleasure to have this opportunity to speak with you today. I have one little issue. I hear you perfectly. I see my presentation, but I lost the Zoom. I lost the Zoom window. I cannot access it, and it's asking me to sign in. I don't know what's happening. I'm so sorry. I might need to.
Maybe if you go and enter again, I don't know.
Yes, I'm so sorry about that. I really don't know what happened.
It's okay, we're fine because this is a live conference, so
okay,
it's okay.
You still see me, right?
Yeah, we see you.
Okay, I don't see a thing. So sorry. I'll be right back.
Okay. Este într-adevăr o provocare tot acest complex în care de la diagnostic, cumva prezentat de domnul profesor Verhulst în cazurile complexe, ulterior recomandarea de terapie care sigur include partea chirurgicală atunci când este necesară, dar sunt situații în care e nevoie de acest suport al respirației, cum spunem noi, suport ventilator pentru managementul tulburărilor de respirație în timpul somnului. Și aici tehnologia a evoluat rapid, aș putea spune, și de aceea cumva trebuie să ținem pasul. I just say, Ivana, that the technology has this evolution very fast and quick, and we as a clinicians need to learn day by day about all these devices.
Yes, and technology is not always your friend. The simple technology, like computers and everything. Thankfully, ventilators are. So I'm Ivana. I'm a respiratory therapist. In Philips Sleep and Respiratory Care, I'm covering clinical application trainings for the region of Central and Eastern Europe with Russia. In the next 40 minutes or so, I'd like to give you an advice how to decide which ventilator will be appropriate for which patient. The very first important step is to achieve patient cooperation by explaining the procedure and what to expect from ventilation. As much as you can, as much as the patient can cooperate and understand. If child needs to play with the mask or apply it to toys, as you seen earlier in a very nice presentation, we should give them time to accept the therapy and adapt to the news that they have to use a ventilator. Next step is to choose and fit the mask. So, for example, this pediatric is a nasal mask that is approved for children with more than 5 kilos. It has this very appealing design with giraffe patterns, so kids find it very fun. It comes packed with 3 cushion sizes: small, medium, and large. And the standard configuration of the mask is that it's vented. This means that you will directly attach a single limb tubing, and exhalation will happen right here at the elbow. There is also a non-vented elbow accessory that I will talk about in just a moment. Next mask is a VISP youth. It is also a nasal mask. Also has a non-vented elbow as accessory, but it's cleared for patients with more than 18 kilos. And it also has 3 cushion sizes: petite, small, medium, and the large. And these cushions would fit pediatric would fit pediatric VISP. So you have actually 6 different cushions with 2 masks. In a dream family of masks, there is an under the nose version, standard dreamwear, then the version with the gel pillows. And also in the nasal category, there is a Dream Wisp, which is a hybrid between the two best-selling masks, Dreamwear and the Wisp, simply called Dream Wisp. And there is also a full face version of the Dreamwear, simply called Dreamwear Full Face. All of these masks come in a small, medium, large, and the medium wide pillows, and can be attached to small, medium, and large frames. And the Dream Wisp nasal mask, so this one, is the only one in this category that has reduced size headgear available and the petite cushion that you might find it even more appropriate for pediatric patients. These masks are cleared for patients that weigh more than 30 kilos. We live in a time of a respiratory pandemic, so there is sometimes a concern and a lot of questions how to filter the exhaled air, because the exhalation happens right at the elbow of the mask. So on the next slide, my intention is to show you what is available. For nasal masks, this is a separate accessory. So you could put the bacterial filter and then put the exhalation. But remember that these are nasal masks. So the patient can still exhale through the mouth. So it is questionable what is the purpose of a vented elbow in a nasal mask. So I'm going to tell you what is the purpose. It is so these masks can these masks can be used on a hospital, on the big ICU ventilators that have dual limb circuit that do not compensate for leak or compensate a little bit for leak. So this is what this is for. So again, we have this mouth opening as an issue that could cause leak. At this time, we should really revert to some older masks, for example, FitLife SE that comes in the smallest size as S, and Amara range, so Amara and Amara Gel SE that also have petite cushions and reduced size headgear, and these are for more than 30 kilos. Next step in this journey is to choose the device. Here you can see the complete portfolio of devices. So BiPAP ST and BiPAP AVAPs can be used in the patients with more than 18 kilos and only for non-invasive ventilation. BiPAP A40 can be used in patients with 10 kilos and up. It can do non-invasive and invasive ventilation, but not life support. And finally, we have the life support category, so Trilogy Evo that can be used for 24/7 ventilation in children as small as 2.5 kilos. I will cover a little bit later what kind of circuit goes for such small patients. Now let's take a look at Dream Station range. So these are NIV ventilators for patients who weigh more than 18 kilos. Some technology highlights include digital auto track. This is for automatic triggering and cycling, so you don't need to set inspiratory sensitivity or expiratory sensitivity. It can compensate for leaks. So this is one of the most important things in non-invasive ventilation. How is ventilator handling the leak that is inevitable? We always have leak in non-invasive ventilation, and we cannot avoid it. Automated airway management is inside. This means that in any mode you can treat the upper airway and open the upper airway automatically by setting the minimum and maximum EPAP, such as what you would do in auto CPAP. So this is like having auto CPAP inside of the ventilator. So EPAP min and max. And it's a feature, so you need to turn it on. For example, you are in the ST mode, where you would normally manually set EPAP to open the upper airway. Here, you turn the AAM to on, and then two EPAPs appear, and you can set them just like you would in the auto CPAP. There is an option to attach the heated humidifier with the dry box technology. This means that you can, it will not spill even if you turn it upside down. Maximum pressure the device can achieve is 30 centimeters. And I mentioned there are two, DreamStation ST and DreamStation BiPAP AVAPs. The difference is that the BiPAP AVAPs has two additional modes. So we have T mode and the PC mode. And as the name implies, it has AVAPs feature for automatic pressure support in the inspiratory phase. Here is the patient that I made up. So it's the most typical patient that I can think of where I would recommend DreamStation BiPAP ST. For example, 10 years old, around 30 kilos, diagnosed with nocturnal hypoventilation due to neuromuscular disease and kyphoscoliosis. I want to point out that in this particular neuromuscular disease that I didn't name, we don't expect bulbar involvement in future. So we don't expect the disease to progress towards the need of invasive ventilation. So we expect non-invasive only. The patient has intact upper airway. You did the sleep study and you see the upper airway is open. When you assess the ability to clear secretions, you can see that the patient has a good cough and ability to clear secretions by himself. And you prescribe long-term nocturnal NIV. And you would go for such patient, DreamStation BiPAP ST. With the settings, I would recommend ST mode. You set the inspiratory pressure to normalize the CO2, for example, 16. So whatever pressure is needed to bring down the CO2 to a normal value. EPAP, I put 4 because based on the information that there is an intact upper airway, and we don't expect oxygenation issues in the neuromuscular patient if this patient is able to clear secretions. Backup rate, for example, 14, and the inspiratory time set for restrictive patient. So 1.7 seconds is considered long for a rate of 14. I provided here the calculation how I came up with the 1.7. I chose for 40% of cycling based on recommendations that we should set inspiratory time between 33 and 50% of cycle for restrictive patients. So 4.3 second cycle times 40% gives me 1.7 seconds. In the monitoring, there is also a little screen for monitoring parameters. And you see, for example, that this patient is reaching 240 milliliters of volume, which you calculate to be about 8 milliliters per kilo. Respiratory rate is normal for the age, and that combination of volume and rate results in a minute ventilation of over 4. And you see that you're reaching the set IPAP. So this is kind of ideal situation for the simplest patients and simplest device combination. Just a little reminder how ST mode works. So if the patient triggers the device, spontaneous breath is delivered, meaning it is pressure supported, but patient decides on the duration of the inspiratory time. If there is no effort from patient, the mandatory breath will be delivered with the set inspiratory time. So the inspiratory time that we are setting in the parameters is for these backup breaths only, while these spontaneous breaths patient is controlling. Now the next example would be kind of a patient that I would recommend DreamStation AVAPs for. So you will see towards the end of presentation, the devices are getting more complex, patients are getting more complex, and patients are getting smaller. So here we have the same age, but this patient is a little bit heavy for the age. So you diagnose him with the obesity hypoventilation syndrome. You also find OSA, but good news is that at least patient can clear secretions. So you also decide on the long-term NIV at night, and the DreamStation BiPAP AVAPs of choice, because you have this combination of ST mode. You have the ST mode in there. You have AVAPs in there to treat hypoventilation. Automatically, you can set the target to, for example, 250, and you have automated airway management as well that will take care of the OSA issue. So you can set, for example, the expiratory pressures to range, I don't know, 4 to 12 maybe, and then you can set the pressure support above that normalizes the CO2. Notice the terminology change. When you turn the AAM on, you are no longer setting EPAP as the inspiratory, but you are setting the pressure support directly. So, for example, 8 to 12 above the EPAP. Again, the same rate and the same inspiratory time, because it's the same group of diseases, also restrictive. So I would go for the inspiratory time of, for example, 1.7 seconds. When you combine AVAPs and AAM in a DreamStation AVAPs device, you come pretty close to a mode called AVAPs AE mode. However, this is not a full AVAPs AE mode, because here we are missing the auto backup rate that AVAPs AE also has. So here we have two separate algorithms. First, you set the target tidal volume that this pressure support will automatically try to achieve by setting the range PS, so pressure support min and max, but also you set the range for EPAP min and max to open the lower airway. So as if the resistance of the upper airway is low, only AVAPs will work based on the tidal volume patient achieves, and it will automatically adjust within the range that you set based on the tidal volume. So only AVAPs will work, for example, if there is no need to open the upper airway. Once the resistance of the upper airway goes up and upper airway needs to be open, expiratory pressure will also adjust to open the upper airway. So pretty close to AVAPs AE mode, but there is no auto backup rate, for example, that A40 and Trilogy have this comprehensive mode inside. Now, moving on to the next category of device, BiPAP A40, that can be used in a patients with the 10 kilos or more. A40 can also do invasive ventilation, but remember, it is not cleared for the 24/7, so it's not a life support category. It can do invasive ventilation at night, for example. I'll show an example patient. In addition to auto track, there is also a sensitive auto track, but also you could set the flow triggering manually if that is desired. AVAPS is inside, leak compensation, integrated heated humidifier with the dry box technology is also there. One addition is the optional battery module that at pressures 12 and 7 and the rate of 12 can provide power up to 9 hours and 45 minutes. The maximum pressure it can reach is 40, so the turbine is stronger than a Dream Station, and it has all of the modes the Dream Station AVAPS has, with the addition of AVAPS AE mode, so the fully automated mode of ventilation that has also automatic backup rate. The typical patient example would be, for example, 15 kilos. I think that's a 5-year-old, diagnosed with the neuromuscular disease, where we don't expect progression to the bulbar involvement in future. But this patient is unable to clear the secretions already. You decide for a long-term nocturnal NIV, but you add also mechanical insufflation, exsufflation to help with clearing the secretions. The device is called Cough Assist. I would recommend setting, for example, a PC mode, and I'll explain why. I don't expect in this weak patient that the patient would be able to hold the inspiratory time long enough and to reach the IPAP you set in the ST mode. So idea also to show you the PC mode. EPAP at 4. I didn't mention before, but there was also no issues with the upper airway. So minimum EPAP and EPAP to normalize the CO2. Backup rate a little bit higher. Also long inspiratory time. So this is also we are still in the restrictive category of diseases. And a reminder how PC mode works. So the inspiratory effort is recognized and acknowledged by a device. So the patient can trigger, but the patient cannot cycle. This means that the inspiratory time is set. So the difference between pressure control and the SC is that the inspiratory time is set for every breath. No matter who triggers it. Is it the backup breath and the time triggers it, or did the patient actually trigger a device? So only inspiratory trigger is possible, but not expiratory, because you have the fixed inspiratory time for every breath. Now moving to the most advanced device we have in our portfolio, Trilogy Evo. So few information about this device. It can do non-invasive ventilation as well as invasive ventilation, and it is a life support category of device that you can use for 24/7 in the kids as small as 2.5 kilos, making this the only device in the category that can ventilate children so small, so non-critical, in the non-critical care area. There is a comprehensive list of pressure and volume modes and all kinds of circuits: passive, mouthpiece, active flow, dual limb. I will cover today only two types of circuits that would probably fit most of your patient needs. Pressure that Trilogy can achieve is 60 centimeters of water. There is a possibility of FiO2 monitoring in case you use low flow oxygen, and so there is a possibility to install oxygen cell. And the battery, so with the 15-hour battery, you can easily reach the other end of the world, and the ventilator will still work without electricity. So 15 hours is really a lot.
May I ask you something?
Yes.
Just before move forward to notions just to emphasize what it is life support. You said before that the other one it was a notes. It is not a life support. So what is mean life support? And the second was when you say the patient failed to trigger the cycle, means that the patient is too weak.
Yes. So when we talk about the cycle, patient cannot hold the inspiratory time at acceptable level that would not cause hyperventilation. Because in the ST mode, patient can have very high respiratory rate because patient is controlling the inspiratory time. If you control the inspiratory time yourself, this would indirectly bring the respiratory rate down and help the patient, and you would be able to ventilate with the pressure you reach. So yes, the need for PC mode, patient is too weak, yes. And the life support category means that device is cleared with all of the settings that the FDA, for example, requires, and the ISO standard require for the life support category. There is the whole list of things that we as a producer must fulfill. So many alarms, so many backup mechanisms inside, and so many what if this happens, then we have a backup mechanism for that. So all of that, the placement of the device into a life support category is on us, and the list is really too long. What we have to comply.
Yeah, it's not only related with the battery. This is why
it has to. Yeah, no, not only the battery. Also, many alarms. That cannot be silenced. So there is the whole list which alarms can and cannot be silenced. Regarding battery, this type of device must have 2 batteries. So that's the story of batteries. In the Trilogy Evo, you have internal as well as detachable, and this detachable you can exchange. You can exchange it in the hot swap manner, so there is no need to stop the ventilator and so on. So it can be continuous ventilation as many external batteries you have. You can just change them all the time. So yeah, but it's not only about the battery. There is also many things that makes a device safe to use 24/7. Yeah, and the alarms are the big part of it.
Okay, thank you.
Did I answer your question?
Yes.
Okay, great. Okay, so there are many circuits available. Not only that, I don't have time to tell you all the details about each circuit, but most of the circuits you don't really need. So let's start with the most common one in home care, the simplest to use in home care, but it's also the most common in a non-invasive ventilation. That's a famous passive circuit that is in a single limb category. So I would recommend this circuit in any patient that has more than 5 kilos for either invasive or non-invasive ventilation. So the primary choice of circuit is actually the simplest one, and it's it connects in a very simple way. So it consists of bacterial filter, tube, and some kind of exhalation port. So you can attach it directly to the to vented mask. So this is the three-piece set: mask, tubing, and a filter. You could also use it with the non-vented mask, but you have to provide exhalation port inside a circuit. You could filter it if you could filter the exhaled air if you desire. And in the same way as a non-vented mask, you would connect it with the tracheostomy. So you would need a little flexible adapter that connects directly to the trach, and then the other side to the exhalation port. So that's all. A very small number of components. This is what it looks like attached to the ventilator. And in a very short video, we'll walk you through how to connect everything.
The passive circuit consists of a bacterial filter, tubing, and exhalation port. Connect the bacterial filter and tubing to the inspiratory port on the side of the device. A leak device, also known as an exhalation port, is mandatory during invasive ventilation or when using a circuit with a non-vented mask. The passive circuit is now complete.
In order to explain the differences between the passive circuit and the dual limb, we first need to define what kind of volumes we are seeing on the screen. In the passive circuit, we display estimation of the exhaled tidal volume. There is no proximal flow sensor near the patient that is measuring exactly how much comes out of the patient lungs, but it's rather a very precise mathematical function that estimates tidal volume. Passive circuits have many advantages. It's a very light circuit, which is very important in children. It doesn't it's not unnecessarily heavy because of the additional sensors and other gadgets that we sometimes put into circuit. All of that makes a circuit heavy. So a passive circuit doesn't have that. It's a very light circuit with the less parts to clean, less parts to connect. It is very silent. This valve is called VII-a silent. Previously, it was called whisper swivel. So that all tells you how quiet this passive valve is. Less complicated to use, and to operate this and to connect this circuit, less technical skills are required, and less parts, less problems. More interfaces are available because you could connect to it any vented mask, and in a sleep portfolio there is many masks as you saw earlier. And the technology that I was mentioning, AutoTrack and AVAPs, can only work if there is a passive circuit. There is one limitation to this circuit, is that it is approved for patients more than 5 kilos, which means that if you would to set AVAPs or use volume ventilation, the minimum set tidal volume is 50 milliliters. So Trilogy is approved. It's called pediatric and adult ventilators. So this is not a neonatal category. I will cover in next what kind of circuit you could use in 2.5 kilo baby, but not passive circuit. It's cleared for patients with more than 5 kilos. As promised, my patient examples are getting more complex and smaller. So here we have a neuromuscular patient where we expect progression towards the bulbar involvement in future. Patient cannot cough, and the only good news is that this poor little kid at least doesn't have OSA. You decide on the long-term nocturnal NIV, but you expect the ventilation to progress, the need for ventilation to progress towards daytime NIV, and later switch to tracheostomy. So you also expect invasive ventilation because you expect that there will be bulbar involvement. I would recommend for the kid that's between 5 and 10 kilos, you cannot use A40, so the patient is too small. So you would have to, and it's not, A40 is also not a life support category for later. So you would have to go with the Trilogy Evo and the cough assist combination. I would recommend starting in the ST mode. It is the most comfortable mode after all, but I would expect progression. With the progression of the disease, I would expect to switch to the pressure control mode later, knowing that this will escalate to invasive. EPAP of 4, as mentioned, there is no OSA. Inspiratory pressure at the level to whatever normalizes the CO2, for example, 16. Backup rate 20 to 24, I think, based on the age, and appropriately long inspiratory time for the restrictive category of the diseases. The most important thing to monitor in the ST is if you are reaching the pressure that you set. Is the tidal volume and the respiratory rate adequate for the patient size, and does that result in the adequate minute ventilation? So is the combination of these also okay? If you think that the patient is too small to tolerate ST, you could also start with the pressure control. That is also okay. Smaller the kid, less chances that the ST will work, but it's worth trying. So here you can see the screen of a Trilogy Evo. For example, EPAP is set at 4, as I mentioned in the example, 16, inspiratory time 0.9, breath rate 22. I would recommend to use auto-track sensitive. This is the auto-track triggering system that designed for pediatric patients and for very weak neuromuscular patients. When you set automatic trigger type, there is no need to set trigger sensitivity or flow cycle sensitivity, so these settings are not available. And rise time 3 means that in 0.3 seconds, you reach 2/3 of the set EPAP. So in 0.3 seconds, you will reach 2/3 of 16. And the total inspiratory time for the backup would be, for example, 0.9. And on the little monitor on the right, you can see that you set the EPAP to 16, you're reaching 15.4. That is close enough. Probably tidal volume of close to 70 is probably okay for the age. I would say the same for the respiratory rate. And the minute ventilation, let's imagine that it's, I don't know, over 2.5 or 3. So imagine that it's also acceptable. But what if this happens? If you are not reaching the set pressure, if you set 16 but your peak pressure is only 9, this would immediately lead to the high respiratory rate and the low tidal volume. That would give you a better minute ventilation, but for the wrong reason. Right, your respiratory rate, the hyperventilation is not acceptable as well. You're not happy with the volume you are reaching. So combination of all of these numbers, it's not good. So the patient cannot stay in the ST mode this way. And I would recommend to switch to the pressure control. So it's the same patient, but later. You decide to go with the assist control pressure control mode. It's just a different name than in earlier devices, 2 letters more to explain better what the mode does. PEEP at 4. I mentioned before that the OSA is not present, and the pressure control to normalize the CO2. So here you can notice that I set it on 12, not 16, because the pressure control level in Trilogy Evo we are setting directly on top of the expiratory pressure. Backup rate also fast, inspiratory time also long, and here you can monitor again, tidal volume and the respiratory rate, is it adequate for patient size, but there are also additional things that you can monitor, such as compliance, resistance, plateau pressure, and auto PEEP, for example, only available in the Trilogy Evo. When it's time to switch to invasive ventilation, you can use the same device, same settings, even the same circuit. All you have to remember is do not forget the exhalation port. So patient, it's a single limb circuit and the patient must exhale somewhere. The screen of the pressure control mode is very similar, except pressure control that we are setting. Here we have 12 plus 4 combination, and that is going to give you 16. In the ST, you would set directly 16 and it's called EPAP. Additional monitoring parameters are seen if you change the view, so you can see compliance, resistance, plateau pressure, auto PEEP. So plenty of things to monitor, and these lung parameters are available only in the modes that offer assisted or controlled breath delivery, and the PC mode is one of them. So these numbers are not available in the ST. And as my colleague pointed out, this is not possible to have the peak pressure of 16 and the alveolar pressure of 27. It should always be less. So I was just playing with the simulator and I couldn't get it to display exactly what would happen in the real time. So plateau pressure we need to keep over 30, under 30, to keep the lungs safe, and it cannot be higher than the peak. I promised to cover one more circuit. The circuits approved for smaller children are these two: active flow and the dual limb. And you can use these two circuits in children that weigh between 2.5 and 5 kilos, but I will only cover the dual limb. So dual limb consists of the two limbs. One is the inspiratory that carries the air from air to the patient, and then expiratory that goes from patient to not to the device, but it also goes out to the atmosphere, because there is a little active valve here. So it only looks like the air is being returned to the ventilator, but it's not. It escapes here. And in order to use dual limb circuit, you must have a flow sensor installed that will measure the exhaled volume near the patient. In the dual limb, we are targeting the expiratory tidal volume again, just like in the passive circuit, but this time we are measuring it because we have the flow sensor near the patient. So the proximal flow, thanks to the proximal flow sensor, we can measure expiratory volume precisely. And how dual limb circuits work is that one limb measures the inspiratory volume, so inside the flow sensor inside of the device, and the expiratory one, you are measuring the expiratory volume thanks to this sensor. If these two volumes are the same, it means it's a closed system. Ventilator will probably like it, and there is no alarms that are related to leaks. But if the two volumes are different, it means there are leaks present, but there is some leak compensation available. So what do I mean by that? In the dual limb, it's probably simple enough to provide invasive ventilation with the cuffed tube, no leak, very passive patient, that's probably simple enough. If you want to do non-invasive ventilation, however, you need to keep in mind that there is always leaks. With the non-invasive ventilation, there are always leaks present. And the only thing that ventilator can compensate for is the loss that happens between the sensor and the device. So anywhere in the circuit that you can open it, ventilator will fix it. But where do the most leaks happen? Most leaks happen around the interface, around the cuff of the tracheostomy tube, and those are compensated only for triggering, but not for tidal volume. So you will not know what volume is being delivered. So even with the very precise flow sensor, if you have a leak, it doesn't work really well. Passive circuit, however, compensates for all leaks. So the intentional one in the circuit that directly at the exhalation port, but also all other leaks at the interface, for example, around the cuff or mask. Typical patient example, so small kid, 2.5 to 5 kilos, with neuromuscular disease, with bulbar involvement, unable to clear secretions. So you are guessing by now, I'm going to recommend Trilogy Evo and the cough assist combination, because this child needs a long-term tracheostomy ventilation. I would recommend the dual limb circuit for this only because the patient is too small to use passive circuit. I would otherwise recommend that. Probably pressure control with the minimum expiratory pressure, but the pressure control at the level that normalizes the CO2. So the same example, just in any other case. So the backup rate appropriate for the age, and the inspiratory time appropriate for the restrictive category. And all the monitoring story is the same. Monitor the tidal volume and rate combination. Is it adequate for patient size? Monitor lung parameters, compliance, resistance, plateau pressure, to see if there is any progression, or maybe the patient needs airway clearance. So this is really really good to have in a home care device, because it can guide parents at home to decide when it's the time for to use airway clearance therapy. Okay, I did go over a little bit over with time, but I hope the presentation was clear, and if you have any questions, I'm happy to answer.
Yes, it's for clinicians, it's always a challenge to deal with all this mix, and the support you gave us and you give us all the time. It's really helpful, and thank you one more time. I have a questions about the mask. You said at the beginning, I just put a note here. What pressure is that for the mask you have under the nose?
Mm-hmm.
Yeah. Is there a DreamWear for a DreamWear?
Mm-hmm.
Is there any issue with the pressure? I always ask this, if we can use any pressure on that mask. It's uncomfortable for patients to use, starting with what age in pediatric patient? What do you think?
The masks, when the masks are designed and developed and tested, we always pass that they can be used up to pressures of 30. So DreamWear mask is one of those where we publish and say to people it can be used. Comfort, on the other hand, is a very subjective matter. So I personally believe it's less, because with any mask, it's very uncomfortable to tolerate the pressure of a 25. So I don't know if you are a fan of high intensity NIV. I am, but I would not use such a small mask for that. I would use a larger mask that can distribute pressure more evenly around the face. So not all the air would be concentrated in a very small area. So one thing is tests. Another another thing is real life and actual patient comfort, which is subjective. So
yeah.
I would say probably not more than 25.
Okay, so and this kind of mask, it's maybe used when we have maybe less compliant patient, or there are also some other situation.
Well, the patient who does not open the mouth, so the smaller the mask, more comfortable is going to be, and less chance you will have for the leak because of the smaller footprint on the face. And as long as the patient is not opening the mouth and not disturbing ventilation that way, you can use nasal mask. The most common advice that is given to pediatricians is use nasal mask, because oronasal mask is not safe, because we cannot trust children that they can take the mask off very quickly in case of vomiting, for example. So there is always this fear of risking the aspiration pneumonia. So for children, smaller mask is better. So the only issue that remains is the mouth opening. So if the patient is opening the mouth and it's leaking that way, you don't have a choice but use oronasal mask, right? So here the training and explanation to the patient and the practice becomes very important, where you need to train the patient how to take the mask off quickly in case of emergency. Patient, not only parents. So it's a little bit controversial. So to be on the safe side, nasal masks for children are recommended more often. For that reason.
Yes, true. And also in neuromuscular patients, they have one more reason: they cannot move so easily.
Weakness, yes.
Yes.
Yes, so nasal mask probably the choice, and we can hope that there is no air leak through the mouth. There are solutions in forms of a chin strap that you can close the mouth, but what happens if the patient is going to open the mouth? It's still going to come through the mouth. It's just going to sound differently, right? You can immobilize the jaw, but it will still, it will still come out.
Yes, I think, and the final question for me is, you mentioned at the beginning the secretion at the very beginning. The first cases, you said that in the sleep the airway are so probably you think at the sleep apnea they don't have sleep apnea. And yes, when you spoke about clearing the secretion, what is the importance of that secretions in this context?
Okay, so if the patient is unable to clear secretions, what I mean by that is that the patient is too weak to cough by himself. And here we have a solution called mechanical insufflation, exsufflation, that will insufflate the lungs, provide a deep breath, rapidly shift to negative pressure, and pull the air out from lungs together with secretions. So this device is intended for patients who cannot cough, so who have peak cough flow less than 270 liters per minute.
And this is also related with what ventilator we choose?
No. It can be used in any patient who has weak cough, requiring mechanical ventilation or not. So even if ventilation is not indicated and the patient is too weak, go for it. Yes. Okay.
So maybe the next time we will meet and we make a practical training. We
I
hope
cannot wait. I cannot wait to travel to Romania. I really cannot. This is
and
really
with
getting...
all the devices to have a practical session, and hopefully this will be very soon.
Me too. Me too. It was great to see you virtually. Thank you very much for the opportunity.
Thank you very much, Ivana, and thank you, Philips, for the support and be a partner at this conference. And I think we will take a break now, 10 minutes break. We wait for the second part of the conference today with very important presentation, and maybe the case with the sleep disorders, breathing in myopathy, we will postpone for the end of the day. So 10 minutes break, we come back at 11:45.
Salut! Ea este apnea. Nu știe să facă prea multe. Ce știe să facă cel mai bine este să ne tulbure somnul. Da, poate fi chiar enervantă. Haideți să vă explic ce este apnea de fapt. Apnea în somn este o condiție în care mușchii din spatele și din părțile laterale ale gâtului se relaxează atât de tare încât atunci când dormi, respirația este blocată pentru câteva momente. Când se întâmplă acest lucru, creierul observă o lipsă de oxigen în sânge și ne trezește suficient pentru ca respirația să revină. Apoi intrăm din nou într-un somn adânc, iar ciclul continuă, fără ca noi să observăm această succesiune. Așa cum spuneam, totul se întâmplă în somn. Chiar și sfărăitul poate semnaliza existența apneei. Dacă un copil sau un adult sfărăie mai mult de câteva săptămâni sau luni la rând, înseamnă că nu respiră bine în timpul somnului. Toate acestea pot duce la un nivel scăzut de oxigen în sânge și niveluri ridicate de dioxid de carbon în somn. Pentru a pune în evidență apnea din timpul somnului, se pot realiza analize specifice, numite poligrafie sau polisomnografie. Despre acestea și despre posibilități de tratament vom povesti mai multe în următorul episod al animației. Până atunci, puteți afla mai multe informații pe pagina noastră de Facebook, Asociația pentru tulburările de somn la copii și adolescenți. Împreună putem promova un stil de viață sănătos.
So hello again, bună ziua din nou după această scurtă pauză, after this short break. We have a very, we continue our conference today with a very important session, in my opinion. So we have together with us at this moment, Professor Mauro Manconi for Switzerland. My words probably will be not enough to describe his work. We try to put some information on the Facebook page on Pediatric Sleep Conference. Professor Manconi was with us also in Bucharest for 2 very practical session training. So we are very happy to meet again, even in online with Professor Manconi. I hope he can hear us and he is connected.
Yeah, I'm here.
Okay, very happy to see you. Because you propose a very, let's say, new subject about sleep-related head jerks, new sleep-related movement disorders in the young age. You are very much implicated in the research, in the clinical research. So again, thank you very much to be with us today.
Okay, so good morning, everybody. It's a great pleasure for me to be here with you for the second time, actually. So I have to thank Michaela for this invitation. It's always a pleasure to be with you. I well remember the last time it was a very successful Congress. So let me also congratulate with you, Michaela, and with all your colleagues, because you are doing a very important job in Romania. And so I think that you are going to develop very fast as a society. So you are having a successful meeting again. So my congratulations to all of you. So I can probably share my slides. Let me see if I will be able. Yeah. Yes, probably now you see my slides. Can you confirm this?
Yes, we can see your slides. Yes.
Okay, I probably need to share again because I need some vocalization audio. So, okay, fine. So can you see my slide right now?
Yes.
Yes, yes.
Okay,
everything.
Thank you very much. So I'm sorry, but it's always a little bit tricky to conduct a virtual meeting. Of course, I will be with you, but maybe next time. Okay, so thank you also for the topic of my presentation, because it's an interesting new topic, actually, because we are dealing with with a new movement disorder that has never been described before, so it's a real new entity. And the reason because I pick this topic is also because this motor event is particularly frequent in adolescents and young, and probably even in children, even if it has not been really described very well. So we are talking about sleep-related head jerks, which has been named in the past as a neck myoclonus. So is a new motor event. As already Michaela told you, my field of interest is mainly on sleep-related movement disorders like RLS, PLMS, and so on. So this is a new entity. And actually, you know that you perfectly know that movement disorders are collected and grouped in one single chapter in the International Classification of Sleep Disorders. So the last edition was 2014. Just to let you know that we are writing the new version, the fourth update ICSD that will come out at the end of the year. So I'm one of the members in revising the chapter of sleep-related movement disorders. So these are the movement disorders that we already know that are grouped in this chapter, and two of them you see in the green, written in green, are the new entity that have been included in the third edition that were absent in the second edition. However, you see that here there is no mention about the neck myoclonus, and this is because it's a new entity and maybe in the future will be included. However, beside the sleep-related movement disorder chapters, you know that in other chapters of the ICSD, there are some other, let's say, sleep disorder that have as a main features always movement, like, of course, REM behavior disorders, or sleepwalking, sleep talking, or epilepsy. All of these disorders have a main movement, or let's say motor features, but they are not included in the sleep-related movement disorders, but part of them are included in parasomnia. However, always also look into outside of this chapter, you don't see any mention to neck myoclonus. And the reason already I told you, it is because it's still a very new phenomenon, and we have only 2 or 3 papers that publish this event, motor event, which indeed is a very, very frequent event, as I will show you later on in my presentation. So if you don't mind, before going into the topic of neck myoclonus, I would like to summarize very briefly and review with you the motor control during sleep, which is an important feature actually that is very important also for the other sleep disorder. So as you probably know, after the discovery in 1953 of the REM sleep by Kleitman and Azerisky, beside the discovery of REM sleep in terms of fast G activity and also ocular movements and dream activity, you know that another features of REM sleep that was immediately described was the atonia. So that means the lack of muscular activity during REM sleep by looking to the chin. So this is the original description by Azerisky and Kleitman. And so they immediately realized that in REM sleep, as you know, there is also a reducing of the tonic activity, of muscular tonic activity, that is, we know that we call today muscle atonia during REM. So, but concerning the mechanism behind the muscular atonia, it's very important to stress that we are dealing with an active phenomenon, not a passive phenomenon. So if you pay attention to the membrane potential of the motor neuron, you see that during REM sleep, there is an active inhibition of the activity of the motor neuron. So that means that we have a system that regulates the atonia and inhibit the motor activity during REM sleep. And you already know that beside the atonia, despite this atonia, there is, in any case, there are some muscular events that escape from the regulation, from the inhibition, that we call muscular twitches. What are the muscular twitches? The twitches are, let's say, very brief myoclonic activity that escape from the atonia during REM, and they occur during REM. And the muscular twitches are physiological phenomena occurring in every subject, but they are much more evident in a young age, like in neonates, and also in some animals. This is a dog sleeping, and you can easily see that during REM sleep is producing ocular movement, as it's clear because it's REM sleep, but also some twitch. You see some twitches, very brief stereotyped movements in a distal limbs, upper limbs, okay? And this is actually exactly the same what's happened in a neonate. So neonates during sleep, in a REM sleep, they may produce some motor activity. We're talking about very brief motor activity, or sometimes it's talking. And these occur only during REM sleep. So why? Probably because the regulation of muscular tonic develop later in the life. So neonates are still not able to control completely their motor activity during REM sleep, and something similar occur in cats and also in dogs or some animals. So probably because in these animals there is not so perfect control of REM atonia during sleep. You already know that now we are perfectly aware of why we have a muscular tonic during REM sleep. So the mechanism, the network that regulates the muscular atonia is very well known today, and we are perfectly aware that the REM atonia is produced by a group of cells, very small nucleus, that is located in the pons, very close to the locus coeruleus, which project down to the spinal motor neuron and also up to the brainstem motor neuron. So the active inhibition is mediated by glycine. Glycine is the amino acid that is a neurotransmitter that is able to exert the muscle atonia and produce a reduction of the motor activity of the motor neurons. And this is thanks to the production and projection of glycinergic neurons to the motor neurons. We also know that strychnine and bicuculline are able to revert the muscle atonia. Why? Because strychnine is an antagonist of glycine, and that's the reason, because by giving strychnine, you may increase the muscular twitch during REM. So in a few words, I'm just telling you that the muscular inhibition during REM is produced by glycine, by a specific nucleus located in the pons, and might be reverted by antagonist of glycine like strychnine. Okay, the other important features, as I told you before, is that this system develop a little bit later in life. So what happens when we have a failure of this system? So if this, let's say, inhibition fails, because you have, for instance, an experimental lesion of the pons beside the locus coeruleus, as you well know, this is a very famous experiment by Michel Jouvet, in which for the first time he demonstrated that if we produce a lesion in the pons very close to the locus coeruleus, we are able to trigger complex motor behavior in animals, like in cats in these cases, and actually the animal is able to produce or to act the dream that is the dreaming. So it's an active dreaming with a motor component behavior occurring during REM sleep. So in other words, the cat is not more able to control the motor activity during REM, and then is mimicking the dream that is doing that case. Okay, so you are perfectly aware that we are talking about something that may occur also in human beings, adults, which is called REM behavior disorder. So the typical REM behavior disorder, like in this case,
Cazzo. Ma i cazzati! Aiuti!
Okay, this is just a polysomnographic example of a patient affected by REM behavior disorder, which is something already very well known. But just to remind you that, of course, in this patient, what's happened is a failure of the atonia during REM sleep, and the patient produce complex behavior because they are no more able to arrest movement during dreaming, okay? And this is because a lesion, neurodegenerative lesion of the pons, very close to the locus coeruleus, as I told you before. So, and of course, REM behavior disorder might be interpreted even as an exaggeration of muscular twitches that are physiological. So it's an exaggeration of the motor activity during REM sleep, which normally is a muscular twitches, very brief twitch, as I showed you before in the dog, that may become a real complex behavior. Okay, so why I'm telling this? Because neck myoclonus, just to come back to my topic, is probably something in the middle between regular muscular twitch during REM, but and on the other side of the spectrum, REM behavior complex disorder. So we are talking about probably an exaggeration of a motor event, which is an amplification of the muscular twitch, which occur in particular in the neck, in the head of the patient. So this is probably the first of ever description of neck myoclonus, which occurred in 1964 by Baldrige. So Baldrige was studying muscular twitches during REM sleep, and he realized that in some subjects, especially in the throat, you see throat, so that means close to the neck, there were a kind of some, let's say, myoclonic events, so some very brief motor events which involved the head and the neck. And this is probably the first polysomnographic description of what we call today neck myoclonus. Then, by going very fast to nowadays, actually, we need to wait until 2010 for the first really systematic description of neck myoclonus. So this description and this publication was published by the group of Innsbruck in Austria, and Birgit Ogel and Birgit Frauscher, they published this paper. This is actually the really first description of neck myoclonus. So what they did, actually, they had the idea to review retrospectively more than 200 PSG in their lab. So precisely, they revised 205 polysomnographic recordings that arrived to their attention in the sleep lab. So these were simply patients, usually adults, and they were affected by disorders, as you can see in this table. So they were regular patients affected by respiratory disorder, insomnia, restless legs, PLMS, REM behavior, narcolepsy, and so on. And they revised all the PSG activity. What do you realize? They realized that in several polysomnographic recordings, they observed these polysomnographic events. So you see here in the left part of the panel, this is an artifact, a very brief artifact occurring in PSG during REM. You see this is a REM sleep because you see eye movements, and sometimes they realize and they observe this, let's say, strip-shaped artifact, vertical artifact, which cover also the EG channels. This was an electromyographic movement artifact covering also the EG channel, very brief, as you can see here. So then they went back to see the video of these subjects and see what's happened in these polysomnographic events artifacts. And they realized that in this artifact was always accompanied by a very brief and fast myoclonus of the neck. So a very fast head movement during sleep, and usually during REM sleep. So it was so frequent that they observed at least one event in more than 50% of their PSG studies. So we are dealing with a very, very frequent phenomenon. They were able also to describe a neck myoclonus index, which was the number of events per hour of sleep. And they also observed that in 20% of the case, these events was followed by an arousal, a cortical arousal. So potentially it can also have an impact on sleep continuity. So, and in most of the case, there were also a chin activation. So the submental muscle was activated. They never observed this motor event in patients treated with benzodiazepine. And also you see here another very important finding. So as you can see by this graph, these events was particularly frequent in young and adolescents. So we are dealing with a phenomenon that is strictly related with a young age. So very important is that by this analysis, this research, they excluded from the analysis all the motor events that were followed by an artifact longer than 2 seconds. And this is a bias, as I will show you later, because of course, if you exclude all the events followed by a 2 seconds of artifact, probably you are not able to see indeed if the motor event it is associated or not with a cortical arousal or with an awakening. So later on, actually in 2014, they published a second paper, the second group, the same group. Before arriving to the 2014, let me stress that they describe these motor events as a sudden and jerky movement involving the head and occurring during REM sleep, especially during REM sleep, but sometimes also during non-REM sleep. More frequent in young subjects, and they consider this neck myoclonus as a normal physiological phenomenon. This is one of the most important statements that I would like to stress with you today. Why they consider this as a physiological phenomenon? Mainly for 3 reasons. So first, because the patient, they didn't complain anything because they were not aware about this motor phenomenon. Second, was very, very frequent, and this is true because as I show you, more than 50% of the patient presented a neck myoclonus. And also the third reason, it was that it was almost not associated with arousal or awakening. And so therefore, they thought that was physiological without any impact on the sleep. But there is a bias in this analysis, as I told you before, because they excluded all the motor events followed by an artifact longer than 2 seconds. So they are not able to really understand if the neck myoclonus has or not an impact on sleep. So once again, in 2014, they stress again the same description, and they publish a paper in which they review all the movement disorder they describe in their sleep centers. And once again, they found a very frequent neck myoclonus, but in this case also in healthy subjects. You see, in this case, they actually excluded all patients affected by a particular sleep disorder, and they focus their attention only in normal subjects, physiological subjects, 100 subjects, and they describe again the neck myoclonus together with other movement activity like excessive fragmentary myoclonus, hypnagogic foot tremor, and so on. And so once again, they state that because it's so frequent also in normal subject, we are dealing with a physiological or normal phenomenon. And once again, you can see in this graph, this motor event is particularly frequent in a young age and tend to disappear in adults and elderly. So afterward, there is no mention about neck myoclonus until 2017, in which other 4 cases, without any particular description, 4 cases have been reported by Iranzo. So we are dealing with the group, sleep researcher group of Barcelona, Iranzo, Spanish one. So 4 cases. And then nothing else. So nobody published again about this strange motor phenomenon until our analysis that was published in 2019. So 2 years ago, we decided to perform a careful analysis of these so-called neck myoclonus. And then we performed a prospective investigation, not a retrospective one. And we, let's say, decided to analyze all consecutive polysomnography performed in the sleep lab of Lugano for 3 months and see how many patients we were able to include with the neck myoclonus. And we decided to include also younger subjects from 14 years of age, and this is different compared to the previous 2 studies. And now we are analyzing also children with this motor phenomenon. And we decided to include in our analysis only subjects they have at least 5 nocturnal myoclonus events in one single night, because we want to be sure to analyze those with more neck myoclonus and not subject with only 1 motor event. And then we decided to exclude all patients affected by neurological disorders. We also excluded all patients with any kinds of medication, just to be more clean, and also patients that slept less than 4 hours, so severe insomnia was excluded. And then all the patients were interviewed. They underwent a neurological examination, neuroimaging, and also the premotor potential, which is the Bereshaft potential, to understand if the motor event was originated by the cortex or subcortical. So, very important, we did not exclude neck myoclonus followed by an arousal artifact longer than 2 seconds. So we keep all the nocturnal events, and so we were able to analyze also those events associated with an awakening or with an arousal. Okay, and also we went back and we included in our analysis only polysomnographic artifact associated with a real visible head movement at the video. Then we measured the duration, and then we also analyzed very well all the associated features with the neck myoclonus. So we analyzed if neck myoclonus were associated with ocular movements, leg movements, e.g. arousal, awakening, stage shift, and also respiratory events, in order to understand if these events have an impact on the sleep continuity. And then we calculated the neck myoclonus index, which was the number of events, and also, as I told you, the Bereshaft potential. This is a back average analysis to understand if the movements that we are dealing with is originated by the cortex or is a subcortical event. So these are the first results that we had. We included 11 patients, 6 male and 5 female, and this is the range of age since the age of 16 up to 59. And these are the reason because they came to our attention, and this is the final diagnosis. As you can see, there are also 2 subjects that they suffer by a specific subtype of insomnia, which is a REM insomnia. So that means that the insomnia or sleep is disturbed only during REM sleep. And so this is something important because it might be possible that the neck myoclonus has an impact on sleep and maybe is not really physiological or normal as we thought in the past. So we were able to study 182 motor events, and with a mean number per patient of 17 events per patient and neck myoclonus index of 2. As you can see here, this is the most important, one of the most important findings. So the neck myoclonus occur almost only during REM sleep, and it's very, very rare during non-REM sleep. So 80% of neck myoclonus is distributing during REM sleep, while less than 20% is occurring during non-REM sleep. So what is the head neck myoclonus? Usually is a sudden rotation of the head, or maybe even a dorsiflexion of the head. I will show you some video example. And even when neck myoclonus occur during non-REM sleep, it usually tends to cluster very, very close to a REM sleep. So it's a REM sleep associated phenomenon. As you can see here, the duration is usually longer than 0.5 seconds. And there is no Bereschaffen potential. So there is no precortical potential. What does it mean? It means that this motor event is not originated by the cortex, but originated by the subcortical network, probably brainstem or basal ganglia. So once again, these are important features before showing you the motor events. And you can see that actually, as I told you before, 80% of the cases occur during REM. The duration is usually longer than 0.5 seconds. So the term myoclonus is a wrong term because the myoclonus is something usually shorter than 0.5 seconds. And as you can see here, only in 14% of the cases this is associated with ocular movements, but very, very important. In our analysis, 62% of the motor events were associated with an arousal, e.g. arousals. In almost 20%, they were associated with a complete awakening of the subjects. And in 52% associated with leg movements and 10% shift in sleep stage. So this is a very important finding. Neck myoclonus was associated in 80% of the cases either with an arousal or with a complete awakening. So that means that neck myoclonus may have an impact on sleep continuity, and so maybe to classify neck myoclonus as a physiological event might be wrong. So this is an example of what we found. So these are 4 polysonographic examples of neck myoclonus. At the beginning here, you see the first picture is very similar to what has been described by Birgit Ogel and Birgit Frauscher. So this is a strip shake artifact associated with a myoclonic events in the chin and subdentale muscles. In this case, as described by Birgit Ogel, there were no arousal associated. So apparently, in this case, the myoclonic event has no consequence on sleep continuity. And this is true in part of the case. But if you analyze also other type of artifact, longer artifact, you may realize, going to the B, you see, that neck myoclonus might be associated with an arousal. This is still a neck myoclonus associated with an arousal, but sometimes might be even longer the arousal, like you see here, and sometimes there is a complete awakening. So this is a neck myoclonus, but after the neck myoclonus, there is a complete awakening. So the patient is in REM sleep, neck myoclonus, wake, and so the neck myoclonus provokes the awakening of the patient. And as you can see here in the last picture, the neck myoclonus provoking a shift from REM sleep, this is REM sleep, into non-REM sleep. So that means that there is an impact of neck myoclonus on the sleep continuity. Let me show you some video example of neck myoclonus. Okay, these are real polysonographic video example. You look to the head of this patient, and when the artifact arrives, okay, this is very small neck myoclonus. See again, look to the head. Okay, you see flex extension of the head. Once again, the same subjects, look to the head. Okay, flex extension, very, very weak flex extensions. Once again, this is the same patient. Okay, you see? And sometimes also leg movement, you see? Okay, body movement and neck myoclonus. Once again, hoop, only head dorsiflexion. Okay, these are all examples. Let me show you some other example of neck myoclonus. This is another subject, and you see the occurrence of a typical artifact here, followed by an arousal. Look to the head of these subjects. Okay, there's something. Sorry, there's something wrong, but I will show you some other example. Okay, you see this woman? Okay, rotation of the head. Once again, look to the head of the subject, and you see that in correspondence of the artifact, you have a leg movement and then an arousal. Look again. Okay, did you see? And also a brief leg movement associated with the arousal. So in conclusion, so we are dealing with a very frequent incidental finding. It may occur in normal subjects, but may also have an impact on sleep continuity. It is more frequent in adolescents and young adults, but probably it's also frequent in children. But nowadays we are studying children in order to see if we will be able to find neck myoclonus also in children. It doesn't originate from the cortex, is a subcortical phenomenon. And let me stress that also muscular twitches during REM and also REM behavioral disorder, both of them are a subcortical motor phenomenon. They don't come from the cortex. But as I've written in blue, there are at least 3 reasons to change the name of the term. Why? Because the duration of the neck myoclonus is longer than what we typically call myoclonus. Myoclonus usually is shorter than 0.3 seconds, while here we are dealing with something that is more correct to name jerk, because it's longer than 0.5 seconds. Also, these motor events occur only during sleep, and in particular REM sleep. And so it is important to place beside the name jerk also sleep, because this is a really sleep-related phenomenon. And also, what you have is not a neck event, but a head event, because when you observe the video, you may realize that we are dealing with an head movement that might be a rotation or even a dorsiflexion of the head. And in most of the cases, it is associated with other events like arousal, awakening, leg movements, and so on. So we decided to change the name from neck myoclonic into sleep-related head jerks, which is also very similar to the nomenclature that we use usually in the international classification of sleep disorder, because there are some other examples like sleep-related leg cramps or sleep-related rhythmic movements and so on. So this is in our opinion, maybe the best term to be used. And now we are submitting a proposal to the American Academy in order to let the sleep-related head jerk enter in the chapter of movement disorder. But of course, we need further investigation, and will be very interesting if also pediatrician will study this phenomena in children. And if you observe the same phenomena in children, I will be very interested in analyze together with you if we are dealing with the same phenomenon. Okay, this is fine. I ended my presentation. I thank you, all of you, for your attention, and once again, congratulations for your successful Congress.
Thank you very much, Professor Manconi, sharing with us this research, these results. Maybe 2 short questions. If is this polysomnographic monitoring is necessary a specific montage, or it's the usual montage?
Oh, this is an important question. Actually, this is a standard montage because, as I showed you before, we are dealing most of the case with the retrospective investigation. In our case, we produce the only one prospective investigation. And if you want to study better this phenomenon, beside the submentalis muscles, you need to record also the splenium muscles. So the splenium muscle is a posterior muscle in the neck, and the best is to place 2 electrodes in the surface of the splenium muscles 2 centimeters apart each other. And this is the best way to study the neck myoclonus.
And this will be a separate channel, And where we insert in the head box? Is there a specific?
Oh yes, you can include in the EMG activity like the chin or like tibialis anterior, perfectly the same. And this is one single channel, two active electrodes placed in the splenium muscles. Sometimes we may also use the sternocleidomastoideo muscles that are two muscles, two bilateral. But in most of the case, the splenium is the best one because usually the patient produce a flex extension of the head and sometimes a lateral rotation of the head.
Mm-hmm. And your feeling is as a clinical implication, can have a clinical impact?
This is the most important question, of course. My impression is yes. Why? Of course, it depends on the intensity and the frequency of the phenomena. But this is actually absolutely the same of all the other sleep disorders, if you think. Because if you have 3 apneas in one night, this is nothing. Or if you have 3 leg movements in one night, this is nothing. But also, this is valid for everything, actually. So probably in my impression is that there is a spectrum disorders in which in one extremity you have some physiological case in which these neck twitches are not so important and probably they do not produce any sleep disturbance. But there is then another extremity of the spectrum in which they are so frequent and so intense that they may interrupt your sleep, as I showed you before, awakening. And this may produce even a fragmentation of your sleep, and maybe this might be the cause of what we call REM insomnia, because you know that now there is a new subtype of insomnia, which is characterized by interruption of REM sleep. Maybe neck myoclonus might interfere with the REM continuity, and maybe might be associated with a new subtype of insomnia that we call REM insomnia. But this is also for children, you know, even rhythmic disorders like sleep-related rhythmic disorder, you know, they are almost physiological because they are very frequent in the children and they tend to disappear in the adult. But sometimes also rhythmic disorder might be so frequent and so intense to produce a sleep disturbance. So probably we are dealing with a similar phenomena, but is a new description. So we need much more investigations and we need the help of pediatricians to describe the same phenomenon in children.
Okay, so we will try to see if we manage this montage you said with the muscles, and if it's necessary, we will send you a short question to help us with the montage, and then we see.
It would be very interesting. Thank you for your collaboration.
Well, we have to thank you for all your sharings and support. And then, yeah, it's also Dr. Anna Castelnuovo with us.
Yeah.
Today.
Goodbye, everybody.
Thank you very much. We will continue with this very interesting proposal, asleep or awake, recent updates on brain activity during sleepwalking. Dr. Anna Castelnuovo from Switzerland.
Okay, I'll try to share the screen. Okay. Okay. Hi, everybody, and it's an honor for me to have been invited to your 7th National Congress. And so, yes, the title of my presentation is Sleep or Awake, recent updates on brain activity during sleepwalking. But first of all, I would like to make a brief overview of my presentation because I decided to first make a short introduction about the clinical features of sleepwalking and related disorders, and then step to the core of the discussion where I would try to answer to two basic questions. So what is going on into the brain of these subjects during clinical episodes, but also in the mind of these subjects during clinical episodes. And the second question will be, but is there anything that is stably abnormal in the brain of these subjects, even outside clinical episodes? And then I will conclude with a few notes about the clinical management of these patients. Okay, as you all know, parasomnias are broadly described as undesirable behavior or mental experiences occurring during sleep or at the transition between sleep and wakefulness. And they are classified according to the stage they arise from. And in this case, we will focus on no-REM sleep parasomnias. And these are the international diagnostic criteria that we all know about disorders of arousals. And here, I just wanted to show you a typical example of a kid that we recently recorded in our lab. And as you can see, it happened in the first part of the night during stage 3 of sleep, like 80% of the cases. He's opening his eyes, and then he's moving his arms, and then he will sit in the bed, and the mother will try to interact with him. So he's calling her, yeah. But he's not answering properly, and this is very typical. And what criteria states is that these subjects are basically unconscious during episodes, and they display reduced awareness of external environments during episodes. And also you will see that the technician is entering the room and this is a very, typical pattern. So he will ask his name, he will try to interact, he will ask what's his name or to name different objects. And sometimes he will answer properly and sometimes not. You see how the EEG has changed. And this is very typical, and this is a confusional state soon after the episode. And of course, the morning after, the kid did not remember anything. As you know, we have 4 different subtypes of disorders of arousals. So we start from confusional arousals that represent the great majority of the episodes, and they pose major problems in differential diagnosis. And then we have sleepwalking with typical episodes of ambulation and complex behavior outside the bed. And then sleep terrors characterized by intense fear, expression of fear and autonomic activation. But the most important thing is that actually all these manifestations can coexist also in the same episode and also in the same subjects in the different episodes. And also the manifestation can change, the dominant manifestation can change across ages. So we can have sleep terrors when the kid is 3 years of age, and then when he's older and grown up at 11 years of 13th year of age, the sleepwalking will be the dominant manifestation. We also know that these disorders run in families. So of course, if you have one parent or both parents suffering from sleepwalking, you have an increased risk of developing not only sleepwalking, but also sleep terrors. And so these are very common phenomena, and this is a recent systematic review. And as you can see, only for sleepwalking, the prevalence in children is 5%. And so if we consider disorders of arousal as a whole, the prevalence is even much higher. And this is just to remind you the most acknowledged ethopathogenetic model acknowledged in the model at the moment, the so-called 3P model. According to which we need both predisposing and mainly genetic factors combined with priming and precipitating factors in order to develop disorders of arousals. Priming and precipitating factors are mainly sleep deprivation, and my clinical impression is that these subjects are often long sleepers, and they had an increased sleep needs, and therefore just sleeping few hours less might cause an increase in clinical episodes. Then, of course, any cause of sleep fragmentation and factors that may increase the number of arousals and awakenings may cause and precipitate a clinical episode. I mean, the association with sleep apneas is the most important one. Sometimes also we have medications like zolpidem. We can have, but I mean, several precipitating like sensory stimuli like touching and sounds and so on. But what I want to stress here is that we also have to not really so recognize factors that are actually frequently reported by patients. There are few reports about stress. Of course, it's hard to study this experimentally, but there is now some literature that is, recognizing even these precipitating factors. And of course, this may also have a consequence from a therapeutic perspective. And the same thing for psychiatric disorders. The field is very debated. As you know, these disorders at the very beginning were considered a psychiatric manifestation, and only in the 60s we had the first clear description and demonstration that they are sleep disorder actually. So since then, this topic is highly debated. What I can say from a literature review is that, in my opinion at least, we have more evidence in favor than against the fact that psychiatric comorbidities might be considered a precipitating factor or priming factor as well as sleep apneas. And for this reason, we also conducted recently a study in children. This is the first case control studies assessing different conditions and abnormal behavior and emotions in children. And we were able to demonstrate that patients that are this red triangle here displays more frequently on average borderline or even pathologic scores compared to controls that are this blue dot here in this figure. Okay, but now just move to the second part, most important part of the presentation. Well, everything started in 1968 when this doctor for the first time coined the term disorders of arousals, implying, of course, that these disorders are generated by an abnormality in the arousal process. And this is very far-sighted interpretation, as we will see in a couple of slides. Another important insight has been offered by Mahowad and Schenk, respectively a neurologist and psychiatrist, that for the first time carefully and detailedly describe these conditions, and they interpret them as overlapping states of being in between wakefulness and no-REM sleep. But before talking about pathology, just few notes about physiology. So, and what do we know about the arousal process? We know that it's a very quick process. It's happening in milliseconds, contrary to the falling asleep process that it takes several seconds. But despite this, we know also that it's not a binary process, meaning it's not an off-on state. It's a very complex process. And also a very heterogeneous process. So we know that while the thalamus display a stereotype activation in between sleep and wakefulness, different brain cortical regions display different brain patterns, and this depends on the brain regions, but also on other different factors. For example, the sleep stage they arise from. So the issue here is that our patients seems to remain stuck not for a few milliseconds, but for several seconds in this peculiar state of being. And this is a graphical representation of the first studies that have been conducted on brain activity during disorders of arousal, so during clinical episodes. Of course, researchers started from a visual analysis of EEG recordings, and they observed already at the turn of the century that episodes were characterized by a mixed activity with both big slow waves and high frequencies. Then in 2000, we had this milestone publication. It's a case report published in Lancet, a SPEC study on a single subject, a single confusional arousal, where for the first time, Professor Bassetti demonstrated that this, the activity during this episode is actually something in between sleep and wakefulness. More specifically, he demonstrated an hypoperfusion of frontal parietal networks compared to wakefulness, and an increase in perfusion at the level of the cingulate cortex and the cerebellum. Later on, we have these three different stereo EEG case reports, so based on intracranial recordings, and that basically demonstrated that disorders of arousals are displays with dissociated activation of the EEG, and more specifically display wake-like EEG pattern at the level of the motor and also of a cingulate cortex and the amygdala, and this of course probably justify the motor behaviors and the emotional manifestation of these patients during episodes. But at the same time, the frontal regions and the associative regions and also the hippocampus are still in a sleeping state. And this, of course, may account both for the reduced level of awareness during episodes and for the amnesia for the episodes. And if this is not represented here, the activity of the thalamus was demonstrated by this latter case report, and that shows a clear-cut increase in beta activity at the level of the thalamus. So as a summary, you can see that the activation that recorded by stereo EEG is very similar to the one that I described during physiological arousals. The issue is that in this case, it's much more prolonged and much more massive. And subsequently, a French group published a case series on 5 different patients with several episodes using stereo EEG, and basically they went farther because they identified 3 different phases of sleepwalking, in this case confusional arousal events. The first phase is a pre-onset, time windows of few seconds before behavioral manifestations, that is characterized by an increase in slow wave activity at the level of frontal regions. Then we have a second phase, few seconds before the onset, after the onset of the episode, characterized by a global increase in power across all frequency bands, mainly at the level of the frontal regions, but also at the level of the insula, at the level of the precuneus, and also at the level of the cingulate cortex. And then in a second moment, after a few seconds, the beginning of a behavioral manifestation, we have a cessation of very low frequency, below 1 Hertz, and the appearance of this peculiar activity, this monomorphic delta activity in a specific region, and mainly at the level of the frontal regions, but also at the level of parietal and regions of the brain. At the same time, also the appearance of high frequency activity at the level of sensory motor regions, the orbital regions, and temporal regions. So they were able to essentially replicate what we already seen in the previous slides. But they added an important addition. They added this temporal dynamic and another important information. Essentially, in some specific areas, we also have an abnormal consistence of slow wave activity and high frequency. So not only in different brain regions, we have different states, but these different states can coexist in the same brain region. And now, this is a case report that has been published by our group using high density EEG that has the advantage to be able to map the entire scalp and not only the specific brain regions where the intracerebral electrode is located. And as you can see here, there is a similar three-phasic EEG pattern. But really, what is really interesting is that for the first time, it has been shown that probably there is also a typical spatiotemporal dynamic, meaning that the episode probably started, at least in this case, at the level of the right frontal lobe, and then spread at the level of the contralateral frontal lobe and the temporal left lobe. And all these three brain regions were highly interconnected, as demonstrated also by connectivity analysis. Here you see this in the video, the graphical representation of slow wave activity. Here, this is the very beginning of the episode, and this is the massive spread of this slow wave activity that I described before. But another important aspect is that it has been studied a large window before the episodes, and what you can see is that we have fluctuation of this activity even before the episode, and the hypothesis behind is that it's like the brain activity of these subjects fluctuates over time, and there are specific time windows in which the activity is much more predisposed and much more likely to develop into a full-blown episode. And this might be important because also suggests that, for example, as a clinical application, we can try to trigger episodes in predisposed time windows in order to record events in lab. That is a major limitation at the moment. Okay, so we saw what happens in the brain during clinical episodes. But the other question is what's going on in the mind of these subjects during clinical episodes. And we know from international diagnostic criteria that usually are interpreted as unconscious states, but we have an increasing number of reports demonstrating that some degrees of mental activities are actually reported by these patients. And this is a recent study by our group where we show that, yes, essentially in children, this might be true. Children almost never remember their mental activity during episodes, but adults more often report some degrees of mental activation. And in the great majority, it might be a simple sequence of images or scattered images, but in some cases is something even more complex, something like more similar to a dream. And here you can see that the degree of recall was highly correlated to the degree of awakening rate, essentially. In other words, of course, subjects are more likely to remember a mental activity if they wake up soon after the episodes. And of course, this also might account for the fact that children do not remember usually their episodes because they have an increased sleep pressure and they rarely wake up soon after the episodes. And okay, and this is, as I told you, there are some extreme cases, I mean, very exceptional probably, but we recently published this case report because these subjects was a sleepwalker with, and at the same time reported very complex mental activities associated with his dreams that were and there was a strong association between his dreams and what was observed by the bed patterns or also by home video recordings. And also this subject was able to describe in very detail his mental experiences and also report hallucinatory like experiences. So he clearly described the home setting environment of his of his bedroom, but at the same time, for example, in this episode, he saw the walls of his room covered by mice teeth. So some additional elements coming, of course, from his mental activity. And of course, when he woke up, he saw his normal room without any additional and scaring elements. Okay, and this just to say that scientists also tried to explore mental activity before clinical episodes. Evidence was really contradictory when different time windows were considered, but when researchers focused only on the few seconds, like 4 or 5 second time windows before clinical episodes, they were able to demonstrate an increase in slow wave activity and at the same time also an increase in high frequency at the level of deeper brain regions, the cingulate cortex. And also there is a single study on brain connectivity before the episode, and they showed a breakdown in slow wave connectivity, an increase in long-term connectivity at the level of higher frequency bands like alpha and beta band. So essentially, to make a long story short, we are able already to observe a similar brain activation during episode, even few seconds before the behavioral manifestations. And this is an ongoing study that we are conducting in collaboration with the University of Bologna. Essentially, we were able to replicate the same finding on a larger scale on 17 subjects and 71 episodes, considering both major and minor episodes, in comparing the pre-onset period to the baseline slow wave sleep. Of course, here there is also topographical characterization, and we see that there is a relative increase of slow wave activity and slower activity at the level of the frontal regions, but also of beta activity and gamma activity, mainly at the level of central region, probably corresponding to the motor sensory primary regions. But what is most intriguing here is that then we tried to compare minor and major events. And as you can see, we could not find a lot of difference. And this is very interesting because one of the main issues of the moment is the interpretation of these minor events. And of course, if we can characterize them as part of the same condition and continuum, also objectively, this also might help the diagnosis in the near future. Okay. Coming to the second question, so what's going on into the brain of these subjects also outside clinical episodes, what we can say is that we have evidence that we have stable abnormalities like sleep instabilities expressed like as an increase in the cup rate. We have an abnormal slow wave homeostasis, as you can see here. So essentially a reduced homeostasis in patients compared to healthy controls. We can have bursts of hypersynchronous delta waves that are not specific nor sensitive, but can help and support the diagnostic process when we record these activities in lab. And also, this is very intriguing, the same stage recording that I showed you before. So in one of the subjects, the author were able to find a similar pattern of activation even outside the clinical episode, and so in different parts of the night without a behavioral correlate, meaning that probably there is something recurrent that is going on in the brain of these subjects. And this has been demonstrated a few years later. So this is a high-density EEG study that I conducted when I was in the United States, and you can see on this side the power scalp topography of 15 patients with disorders of arousal, the power of 15 controls, and as you can see from the comparison and of normalized power topographies, we have a different pattern of distribution of slow wave activity, with a relative decrease at the level of central brain region and increase at the level of frontal brain regions. And this pattern could be observed in all non-REM sleep stages, but also to a lesser extent also in REM sleep and during wakefulness. And at source localization, the relative decrease mapped at the level of the cingulate cortex and the precuneus, and also at the level of motor regions, while relative increase mapped at the level of the left ungulate gyrus and the basal forebrain. Okay, and just a few notes because it's important to show you that different authors also tried to characterize brain activation in using different imaging techniques. And as you can see here, in this TMS study, using a specific pattern of stimulation, also were able to demonstrate a reduction in the inhibitory circuits at the level of when stimulating the motor cortex. Then we have this PEC study that was performed in sleep-deprived subjects during wakefulness that showed an hypoperfusion of the inferior temporal lobe in patients. Then we had this structural MRI study that essentially showed a reduction in gray matter volume at the level of the mid-cingulate and posterior cingulate brain regions, that are regions that are associated with the motor control. And then finally, we have this PECT study doing both wakefulness and slow wave sleep that showed that in both conditions, we have a decrease in perfusion at the level of frontal brain regions. And during wakefulness, this hypoperfusion will interest also parieto-temporal regions. And during slow wave sleep, the post-central gyrus, the insular, and the superior temporal gyrus. And then there are, I know, two ongoing studies on fMRI. but we don't still have published results, so I won't go into the detail of this. And finally, just to conclude, as I already mentioned, the diagnostic criteria are mainly based on the clinical interview, but it's really important to stress the fact that when we, at least when we have an atypical pattern, so when we have a presentation during adulthood or persistent in or frequent episodes during adulthood, or we have several episodes also in the last part of the night, negative family history, stereotype features of the episodes, or the suspect of another sleep disorders like sleep apnea, a video polysomnography is really mandatory. And I mean, this is a recently published questionnaire, the arousal disorder questionnaire, that is tailored on international diagnostic criteria, which may support the diagnosis. And if negative, we strongly suggest to perform a video polysomnography. One of the limitations of video polysomnography is, as demonstrated by this study, even if we record subjects for more than one night, the possibility to have full-blown episodes during the recording night is pretty low. It's between 5–6% of the cases, maybe a little higher for children. And I won't go into the details, but researchers are trying to characterize minor episodes in order to using, for example, video information or information from EEG channels, or a combination of information between different polysomnographic channels. And so we are trying to really to move forward the diagnostic process in order to have an objective evaluation of these events. And essentially of minor episodes, because this is what we can capture with polysomnography. And regarding treatment, I mean, as you know, safety measures are the mainstay of the treatment. Of course, we have to find and manage and treat, when possible, precipitating and primary factors that I already described. As I already said, psychiatric comorbidities are still under evaluation, but there is a recent retrospective studies that suggests that actually treating at least a subset of patients with significant psychiatric comorbidity might be helpful. And regarding treatment, we don't have really a lot of strategies. We only have 5-hydroxy-level hydroxytryptophan at high dosages for children, and clonazepam for adults. Instead, other treatments like antidepressant and melatonin are very debated. And the fact is that we don't have good trials, double-blind trials. And this is the reason why I want to conclude saying to you that I think that the only solution to progress in research will be to create international group cooperation for these pathologies, to really develop a home portable device to record episodes at home in the real environments. And only when these two goals will be achieved, we will be able to perform good double-blind treatment trials and large-scale basic research studies. And yes, that's it all. And thank you for your attention. And I'm here for any question.
Thank you very much. It's for we as the clinicians to see how much effort it's in behind all the research you done, and still the future in this research. It's very nice that and very helpful also for us as a clinician to see all these insights. even though for a moment there is maybe as a treatment or clinical, it's maybe not so important, but as you said, the future research can bring us a lot of help. I'm not about the arousal questionnaire you spoke. Is this questionnaire available also for children and adults? I'm not familiar with this questionnaire.
Yeah, it can be used also with children ratios that has, I think it has not been validated for all languages. Of course, it's just in English and Italian, I think. But yes, potentially it can be used also for children. And
yes, we have a question regarding the treatment. Of course, as a clinician, what we can ask if localizing brain activity could help for choosing the treatment. Maybe this is a question for future.
yeah, well, as I shown before, knowing, I mean, what is going on in the brain of these subjects might help in different ways. So we can understand, of course, the mechanisms and so develop different treatments. But also, as I showed you before, for example, if there are specific time of windows where episodes are more likely to occur, of course, we can also trigger events in lab, and this might help also the diagnostic process, because now we can record only minor episodes, and this, of course, might not helpful sometimes.
Okay, if there will be some other questions, I'm not sure that you can stay with us, but I can send you and come back to our participants if you agree.
Sure.
Yes.
Sure. I can stay here for a while.
Okay, thank you very much again. Anyway, the next presentation is also, I think, important contribution in this field is coming from Professor Raffaele Ferri from Italy. I understood that he is with us at this moment.
Yes, I'm here.
Good morning.
Bună dimineața.
Bună dimineața is already noon in Romania, but thank you that you can join us, although it's a time zone difference. Because it looked like this sleep, restless sleep, it's a very broad field. So thank you for your participation and support.
Okay, it's a pleasure for me to be here and that I've been invited and have the opportunity to speak about this new condition. So I can share my screen, no?
Yes.
Okay, I share my screen. And here it is.
So I decided to go directly to presentation because we announced about your activity before the conference and also on the Facebook page of the conference. So I think who already is registered and now want to listen to your presentation already know about your activity.
Yeah, no problem whatsoever. So just the first slide that shows on the bottom of where I am at the moment, which is in Sicily, and we can see the volcano. Okay, so I will talk about restless sleep disorder. This a new sleep-related movement disorder in children. When I first met this colleague called Lourdes del Rosso in America, it was the APSS Congress in Boston, and we discussed about these children that were quite frequently seen in her lab that were referred because they had this restless sleep. And this restless sleep was characterized by continuous movements during sleep, very frequent movements, and not stereotyped usually movements. And these children did not fit any criteria for any already known condition at the moment. So we wanted to focalize on them and see if we could identify a set of features that could distinguish these children from others, and to understand if it was a separate condition. At the moment, we were not sure. We wanted to know. Also, usually what happens is that the parents come to the doctor and say that they children have frequent nocturnal large body movements that involve the limbs, the head, and the trunk, that the sleep is restless, and that sleep is disrupted. But there's not really an awakening. These children have no problem falling asleep and also returning asleep after the movements. Sometimes they don't even wake up at all. These movements can cause an arousal, can cause an awakening, a brief awakening, but they have usually no problems. But also there is a daytime impairment, which includes daytime sleepiness, but sometimes it is just irritability and hyperactivity. That is clearly referred to the fact that they do not sleep well. Usually, parents also are quite precise in describing these things, and they say this child is different from the brother or the sister and the other siblings, and so they can say that there is something different in their child. And we found that all children with this sleep that we call the restless sleep disorder had the low ferritin levels, and we compared the PSG data with a group of RLS children, and we saw that the sleep efficiency was decreased, the same as the RLS, but sleep latency was not prolonged. While in RLS, of course, sleep latency was prolonged. And we proposed this restless sleep disorder as a new diagnostic category with specific clinical and video PSG features. And we say that it is possibly associated with iron deficiency. Sorry, it is RSD, not RDS. And the second study that we performed, I let this video go so you see some example. These are multiple episodes that are shown in this video. We did a video polysomnographic analysis, and with the video polysomnographic analysis, we precisely counted and characterized also from the video point of view these movements, and we also had a normal control group and a group with RLS, and we saw that children in RSD had a higher number of movements, and you can see that the difference is statistically significant. And we also evaluated that a threshold of 5 movements per hour is a good threshold to distinguish between these children and the other groups of children. And also we could also observe that there was not a particular distribution during the night with exclusion of the first hour, but this is because probably not all of them were asleep at this time. And as you can see, there is a presence of movements throughout the night and not distributed in a decreasing way, as we can, as an example, see in children with RLS with their periodically movements. Periodically movements typically decrease during the night, while these movements are distributed, equally distributed along the night. Let me go on. So we can see here what are the features that we identified. So we have large body movements in sleep. We have sleepiness and behavior concern during the day for the diurnal symptoms. And these are different from what you find in other groups, such as, oh, sorry, I have to go back. I pushed, here we have RLS, PLMD, rhythmic movement disorders and bruxism, other sleep-related movement disorders that we have put in this table for a comparison. You can see the body movement index is more than 5. There is an increase in awakening. There is a decrease in total sleep time. We should not have leg movements because if we have leg movements, especially PLMS, but you know that in children the periodicity can be very low or absent. You have other type of movements. If you find many movements, then you might have a condition of PLMD as an example. We don't know much about the family history and the comorbidity at the moment. Probably there is an iron deficiency mechanism, and probably at that moment we were suggesting iron supplementation could be a treatment option. You will see later that we went on with this, which is this one. Then we tried our idea to treat them with iron, and we used a group of children with restless sleep disorders, and we compared two types of treatment with oral iron and intravenous iron. Ferritin changes much more with intravenous iron, as one can expect, than with oral iron, but there is an increase in ferritin also with oral iron. But as you can see here, especially from the clinical point of view, measured with the CGI improvement scale, here in this scale, a smaller value of this scale means a better improvement, okay? So you see the median was 2 with intravenous iron and 3 with oral iron, and this was significantly different. So the effect of the intravenous iron was not only evident at the level of the ferritin, but also at the level of the clinical level. And you can see here the other parameters. So we can already now indicate that this disorder can be treated with iron, especially with intravenous iron. Then we wanted to understand a little bit more about the mechanism of sleep disturbance, because it was not a huge sleep disturbance, but it was mostly at the microstructure level. And we used this measure, that is the cyclic alternating pattern. I have reported here on the top the basics of what is a cyclic alternating pattern. Cyclic alternating pattern, for those of you who do not know this type of scoring of sleep microstructure, is characterized during non-REM sleep by the occurrence of sequences of these events with higher amplitude with returns to the baseline. And this is repeated in a quasi-cyclic way. And a CAP cycle, this is called phase A of the CAP, when there is an increase in amplitude, the phase B a decrease, and a sequence of a phase A plus a phase B is a cycle, and then a sequence of a minimum, with a minimum of 3 phases A with the 2 phases B in between them, is called a CAP sequence. And when we measure the duration of this CAP sequence, and we make the ratio between the duration of the CAP sequence and the duration of the total non-REM sleep, we have the so-called CAP rate. CAP rate expresses the percentage of non-REM sleep occupied by CAP sequences. We indicated here that K complex, a single K complex, is not a phase A of CAP, okay? But when you have a sequence of a couple at least of these K complex, they can constitute a phase A. Or they can be slow waves, they can be mixed slow waves and fast waves. And based on this, you can have 3 types of A phases. The one is mostly constituted by slow waves, and this is the power spectrum that is just in the delta band. And then you can have on the other side mostly fast waves. This is more similar to what you recognize as an arousal. In fact, there is a an overlap between CAP and arousals, with the arousal, the definition of arousals. But CAP includes also the few slow waves that often, very often, precede the arousal, while the arousal is limited to the analysis of this part of the tracing where you have a shift towards higher frequencies. And this is called A3, which is the CAP event that is more disturbing. And you can see the spectrum is characterized by a clear peak here, in this case, the alpha band. And the A2 has an equivalence of slow and fast waves. So we call them A1, A2, and A3, but they are all in the same line of a change in the level of arousal. Even the slow waves are a change in the level of arousal. This is the very quickly and very briefly what CAP is. But this is just to tell you that we can measure sleep instability by measuring CAP. This is a nice paper that you can refer to understand more about CAP. And when we analyze this in children with RSD, restless sleep disorder, we found in particular that the P duration was shorter, and this was reflected by a shorter CAP cycle duration and accompanied with a longer CAP sequence duration that points to a microstructural change that is during, of course, the period when there was no movement. There were no movements, of course. And this subtle but significant change was something that was interesting to us, that meant that we could pick up some fine change in the sleep microstructure of this subject with an increase in sleep instability, non-REM sleep instability. So we could demonstrate an increased non-REM sleep instability at the end of the day. The other thing that we tried to understand is if there were changes in heart rate regulation, in heart rate variability. And we did this study by using the spectral analysis of heart rate variability. This is an example of what we do, and what we consider usually it is a high frequency band and a low frequency band, and in particular the ratio, the relative proportion of these two bands gives us an idea of the balance between sympathetic and parasympathetic system. You know that during sleep we must have a parasympathetic predominance, and when you have a disturbed sleep you can have a decrease in this parasympathetic predominance, and this is what we found in RSD. We had an increased sympathetic activation during sleep, in particular during the slow wave sleep, when the sympathetic activation should be lowest during sleep. Okay, and this was especially up during slow wave sleep, but not during wakefulness. While we had also a control group of RLS children, they had, as we could expect, a sympathetic activation also in the quiet wakefulness just preceding sleep, as an expression of the hyperarousal state accompanying RLS that is maximum in the evening time, when there is the increased severity of RLS symptoms. So it's also, in this case, we could see differences between RSD and RLS expressed by a different pattern of change of heart rate and of the heart rate variability and of the corresponding autonomic system balance during sleep. Another thing that we tried to understand was if there were changes in sleep spindles, always with the aim to characterize the finer changes during sleep in these children. And yes, I can say what we found especially this but children with RSD are the longer frontal spindles. As sleep spindles are are believed to be involved in protecting sleep from being they favor sleep stability. This is a little bit the contrary of sleep instability measured by CAP. In fact, spindles are not considered by the CAP method of analysis because sleep are on the opposite side. They usually indicate sleep stability. And they probably are, in this case, a counteracting mechanism occurring during the same sleep period to stabilize an unstable non-REM sleep. So there is this attempt of the brain uh, to mitigate a little bit the effect of the unstable sleep that accompanies RSD. So as you can see, we were going a little bit more deeper inside the neurophysiology of this disease, also of this condition, this disorder, more than a disease, because we want to understand better the mechanism and, of course, with the aim to understand better what to do with these children. We wanted also to understand what was the prevalence of this disorder. We could not do something in the general population. To do that, we need much more tools and grants and support. But we could understand this among a numerous group of children accessing a single lab that was the lab in Dr. Del Rosso in Seattle. And I don't remember if there were about 200 children that were consecutively recorded with their PSG for various reasons and accessing their lab in Seattle. And we saw that restless sleep disorder was found in 9.1% of children. So 1 out of 10 children seen in their lab had a restless sleep disorder, which was roughly half of the prevalence of restless leg syndrome in their clinical sample. Of course, this is a clinical sample. It is not representative of the general population. Obstructive sleep apnea can be present in a much larger percentage. You can see that if you sum up these percentages, you will have more than 100% because comorbidity is very frequently found. And as in other, also in adults, you can see that sleep disorders are frequently in comorbidity. But this is restless sleep disorder that was not comorbid with any of the other condition that you can see here. So in this case, restless sleep disorder, because restless sleep disorder cannot be diagnosed within other types of comorbidities, sleep comorbidities, as I will show you later. But it has to be a pure condition because restless sleep without a disorder, restless sleep is a symptom of many other conditions that affect sleep, as it is easy to understand. But when it occurs by itself, it is called restless sleep disorder. And it is the only manifestation of the sleep disorder. We have started diagnosing restless sleep disorder in children who have other types of disorders, and it has been possible to disentangle a little bit this condition and to understand that one is not just the consequence of the other. As an example, this is a very recent article published in Sleep by a group of colleagues from Turkey. As you can see, they were able to diagnose REM, restless sleep disorder, in children with non-REM parasomnia. You have just heard about non-REM parasomnia in the previous presentation. by Dr. Castelnuovo. And you see here, these children, they were able to analyze 28 patients with non-REM parasomnia. And among these 28 patients, restless sleep disorder that was independently associated with the parasomnia was present in almost 1/3 of children. If you had both conditions, non-REM parasomnia and restless sleep disorder, sleep quality was worse, of course, than in children with the single non-REM parasomnia. And they found also in this case, they found an increase in sleep instability. These authors also evaluated CAP, and they found that in addition to this increased sleep instability, as already been described in REM parasomnia in the past, that is especially the instability of of deep entry non-REM sleep instability, these children who had also RSD had an increase in the CAP subtypes A3 that are frankly arousals. And they concluded that RSD associated with a worse sleep quality and increased arousal and should be always questioned in children when with non-REM parasomnia. So when you make a diagnosis of non-REM parasomnia in children, you should use and ask the right questions to see if these children have also restless sleep disorder. Then the International RLS Study Group decided to establish a task force to go a little bit deeper in this topic. And this is the task force that was established at the first time that made an extensive review of the literature to see what is the frequency, the prevalence of restless sleep in children, and in which condition. So I go, and in this review we proposed a simple diagnostic algorithm to identify the secondary sleep, that is the restless sleep that is caused by another condition, and restless sleep that is primary, that is not secondary to any other disorder, that is called restless sleep disorder. As it is a simple algorithm, as you can see here. Okay, although RSD, restless sleep disorder, is a primary sleep disorder, and has had been described only in 4 papers at the moment of this review. The complaint of restless sleep is often seen in children with other sleep or medical condition, and a high prevalence was found in children with other sleep disorders, such as especially obstructive sleep apnea and PLMS. But also remember all those conditions characterized by pain persisting during sleep. An example, otitis media. Otitis media is accompanied by restless sleep during the night. Or other conditions characterized by sleep instability, such as sleep nocturnal epilepsy, as an example. Sometimes we found that the caregiver perception of restless sleep was the cause of restless sleep. That means restless sleep itself could be questionable at that moment. The topics that we found to be very important was the fact that restless sleep had, in fact, high prevalence, was with a variable etiology, but was always accompanied by diurnal daytime impairments. And then, of course, as I said before, we indicated the need to identify primary restless sleep disorder among the big number of secondary restless sleep. And because we need to develop clinical trials and the treatment algorithm, especially for this second form, that is restless sleep disorder. Another task force, mostly made by the same people that you have seen before, met always within this initiative of the International RLS Study Group to establish international diagnostic criteria. And these were published also in 2020 in Sleep Medicine. And you can see here the diagnostic criteria for restless sleep disorder. And all these criteria must be met to be able to diagnose. I can go through the criteria because it is important to define them very well. So you must have a complaint of restless sleep as reported by patient, parent, caregiver, or bed partner, or by the patient himself or herself. Restless sleep movements involve large muscle groups of the whole body, all four limbs, arm, legs, or head. They are gross movements. The movements occur during sleep or when the individual appears to be asleep, at least. Video polysomnography shows a total movement index by video analysis of 5 or more per hour of sleep. This implies that video polysomnography is needed to make this diagnosis. You can suspect this diagnosis when you have not recorded video PSG, but to confirm it, you need to record video PSG. Restless sleep occurs at least 3 times per week. It must be something that occurs in a significant number of nights. If it is one night, it can be just something occasional and not really constitute a disorder. It has been present for at least 3 months, so it is a chronic condition, not an acute condition that is probably the consequence of another cause. Then restless sleep causes clinically significant impairment in behavioral, educational, academic, social, occupational, or other important areas of functioning, as reported by the patient's parent, caregiver, or bed partner, or by the patients. Examples are daytime sleepiness, irritability, fatigue, mood disturbance, impaired concentration, or impulsivity. Then, at the end, it is important to underline the condition is not better explained by another sleep disorder, medical disorder, mental disorder, behavioral disorder, environmental factor, such as another sleep disorder, or the physiological effect of a substance. If you take too much caffeine at night, you might have this type of disorder. We also indicated that there are supporting findings. They are not within the diagnostic criteria that are these here, these 8 criteria here, but they can support the diagnosis. That is the fact that the large body movements during sleep typically occur throughout the whole night. They are not concentrated on the first half of the night, as an example. The delayed sleep onset is uncommon because that would make us suspect the presence of RLS instead of RSD. Of course, we indicated the fact that these criteria are intended for the diagnosis of RSD in children and adolescents aged 6 to 18 years, because this is the age range in which we observed and described these first case series. But in the future, we are quite confident we can extend this age range to children, especially to younger children. We have no yet clear idea how to diagnose RSD in adults, and if it does exist in adults, we need to study these things. As a last aspect, I have to show you, if I have time, I hope I have time, 5 minutes. This last effort of a smaller group, a smaller task force endorsed by the International Study Group, that wanted to establish criteria to score these large movements, large muscle group movements, we call them, in a PSG without a video, because we understand there is a lot of recordings available from the past, and also video PSG is demanding from the laboratory point of view for recording it and also for scoring it, because you need to stay in front of the video count. But it might be easier to count them on the PSG. And so we established this task force to develop new criteria, and we did it. And these criteria have been published just recently, as you can see. And this is a very, very recent publication. We started from some data coming from video analysis. And we saw that the duration of movement established on video was had this distribution quite similar in control children. Don't consider the height of the peak because it is just a percentage of the total. Of course, if this was an absolute measure of the number, RSD children would have the highest peak. These are the RSD, the blue one. But in terms of percentage, they were very similar between controls, adult controls, and RSD children and RLS children. So this helped us to understand the minimum and the maximum duration that we could consider. And these data came from two previous publications, one from our group and another one from the group of Federica Provini in Bologna, in Italy too. We started from 10 questions that we wanted to address, and while addressing these questions, we established the criteria. And we decided that this movement could be called large muscle group movement, and we would abbreviate with this acronym here, LMM, which is different from PLMS, from other types of acronyms. And I wanted to just to show you very briefly the criteria, not to explain them because you can find them in the paper, but the idea is that we wanted to use all the signals available that could, as an example, these are signals that are attached to the body and record electrical signals. And of course, not only the signals that record directly EMG can be used, but we can find EMG artifacts, or in this case, it becomes a signal, also in the EG signals, in the EOG signals, and in the ECG signal that are recording electrical fields. So these are all good for our scope to detect movements. But also body position can be used as an optional, or other EMG signals channels. As an example, in the labs that use these the flexor digitorum superficialis or flexor digitorum communis, sampled as per the manual of the American Academy of Sleep Medicine, can be used, or paraspinal muscles. As an example, we can measure these for the diagnosis of propiospinal myoclonus, or as an example, the masseter electrodes that are used for the diagnosis of bruxism. Okay, so we can use all these type of signals, and then I don't go through all these, but I just wanted to tell you that what we are looking for are movements that last from 3 seconds to 30 seconds in children, or from 3 seconds to 45 seconds in adults. These are gross movements. They are not short things. They are quite important movements, and they're quite evident when we plan. And what we look for is not only the occurrence of EMG activity, but also the occurrence of movement artifact. That is usually evident like very slow waves overimposed to the signals. And these must involve at least 2 channels of those that I have indicated before. Again, the criteria are a bit more complex than what I'm telling you now. So please refer to the paper to go through these criteria, and then also how you score them. Of course, you have to take note of when it occurs, how much it lasts, how long it lasts, when it occurs. But there is a specific peculiar feature in these criteria that is different from all other criteria that have been recommended until now in the, as an example, in the ASM manual for scoring sleep, or in the criteria for scoring PLMS by the WASM, and that I will explain you here, especially in this last example. If we have 3 epochs, and the movement occurs here, and the movement obscures the EEG, so that you or causes an awakening. The movement, we score this movement as a large muscle group movement, which starts with the beginning of the first EMG signal here and stops where we see the last movement here practically. Per ASM manual, this epoch must be scored as wakefulness. So we would lose this movement, we would miss this movement if we were to assign this movement to a wakefulness epoch. So in this case, when the movement itself causes an awakening, we must assign the movement an awakening and causes the scoring of the epoch in which the movement occurs as wakefulness. So it is the first wakefulness epoch after sleep. Then the movement is assigned to the sleep stage preceding it. So this movement, those cause an awakening, occurs during an epoch that we must score as a wakefulness, but is assigned to the sleep stage that characterize the epoch preceding it. I hope this is clear. In this other example, the movement, those not the epoch in which the movement occurs, is scored as a sleep epoch, so the movement is assigned to the same stage of the epoch in which it occurs. These are different examples, these are different schematic examples, and here are some example from the real recordings. As you can see here, it is exactly this case. You see that the movement causes an awakening. We score the movement and we assign the movement to N2. Here, the movement is too short to change the scoring of the epoch, that is N2. The movement occurs in the second part of this epoch. This epoch still scored as N2, but as per ASM manual, the following epoch is scored as N1, but this movement is assigned to the epoch N2. So I want to finish here to invite you to read this paper that I have mentioned before, if we are interested in scoring these movements and diagnosing RSD in children. Thank you very much for your attention.
Thank you very much. Yes, we are interested in scoring and diagnosis. So I was thinking at this moment that when it comes to ask questions, first, maybe you should know something and you should know what you want to ask. But I think for this sessions, the presentation were, I have to admit that there are new for our practice. And definitely because you were together with us and we had access at this all information, I think it's a really step forward for our practice. And maybe immediately we will, as you said, read the paper with all the details, and also about the head movement, to try to see exactly how to make the montage, how to score, and also this gross movement.
Yeah, but please understand one thing. To apply these rules, you don't need to modify your montage. You can work with the standard montage suggested by the American Academy of Sleep Medicine manual. So if you use that montage, you are okay.
Yes, but we have to read how to score.
How to score, of course. It's not very difficult. Once you understand the spirit of the thing, it is not difficult. Also because these are evident events. They are not events that you have to pay attention to the little thing, you know. They must last at least 3 seconds. So these already distinct. The one problem is that I did not say is when there is another movement that can be classified as an example. If you have a movement that can be classified as a PLMS, that is included in a sequence of periodic movements, then we state that it has to be scored as PLMS and not as, because if not, we would have an overview. My personal impression and conviction is that this movement can coexist with other movements, but for the moment, we decided not to go into this because we need more data to give some more precise information. So we prefer when there's a coexistence between other types of movements that can be scored with other rules, you have to score those ones and not score it as element.
Mm-hmm. And from the clinical, maybe practical meaning, is there any, what is your impression about the possible treatment, or how should we advise the patient, the parents?
We have more data now about iron treatment than what I've shown you in the publication. And we see continuously, we are convinced that iron treatment is effective in these children, and that the effects are quite significant and impressive. And with iron IV, of iron, you just need usually one single infusion that can be repeated after months, you know, but it is incredible, it works. And also what we have found, increasingly we found, because now we are increasing the number of children that we have observed that we are classified with this disease, is that these children have ferritin levels usually even lower than those with RLS. And they probably ferritin levels and iron is more important in this condition than in other movement disorder during sleep. And for us, this is a movement disorder during sleep. We are in touch now with the American Academy of Sleep Disorder to see when it will be included in the new classification. But as you know, the new classification, the ICSD-3 is now under revision, but it is just a light revision, and they are not including new diseases. So we have to wait for the ICSD-4 that we don't know when it will be done. So, but at least we hope that these criteria for scoring LMM will be included in the manual, not in a long time. We hope so.
Yes. Okay. So I don't know if there are any other questions. Thank you. Thank you very much.
Thank you. Thank you for your attention.
Maybe we will stay in contact for a while on email, I mean, to ask some question about what you presented, and maybe to immediately learn about all this and to implement in our clinical practice also in Romania. Yes, and maybe
no problem. No problem.
yes.
No problem.
There is a question: what target we should have for ferritin in this?
The target is always the same. You know that we consider a level, preferred level, at least above 50, but I would say even above 70. Even if it is without oral iron, this is a difficult target to reach if you start from 15, as an example, because the average increase, if I remember, was less than 20. So it is a difficult target, but you can see the clinical effect even with this smaller. But of course, with the IV iron, the target can be reached much easier, much more easily, and the therapy is more effective.
Mm-hmm. Yeah, maybe, and we should monitor, repeat the PSG after the treatment, or only?
No, we have not done that, but it is sufficient a clinical monitoring, and because the parents are quite well aware, the parents are quite well aware of what's happening, and they usually report a good improvement. If you are not sure and you want to repeat, and there is, I would repeat PSG, especially if there is no improvement, because no clinical improvement, because the child might have another condition that explains the persistence of the disorder, and that has not been picked up with the single PSG. We don't know this. We have no idea about the night-to-night variability of these features yet. There is a lot to be done still, no? So yes, to repeat it when the response to the therapy is not satisfactory, yes.
Okay, thank you. Thank you again.
And bună tuturor.
Bună ziua. I have a few slides for a presentation, a case, which I postponed earlier, and I will try to present very briefly. It's a case with a child with myopathy and sleep disorder breathing. Well, I briefly just wanted to revise what do we search about respiratory breathing in the sleep. So when we don't have the normal, because in our audience there are also a general practitioner, when we don't have a normal respiratory breathing, then and we notice a stop of the respiratory pattern, we do mention this as an apnea, and this is let's say a pattern of sleep during the night when we have a recurrence of the non-REM and REM sleep with more REM sleep in the morning. If we just only have a reduction on the of the flow with following the desaturation or arousal, we then score as a hypopnea. Of course, there are more information and more details in scoring, but in general, we name it in this way. But sometimes even if we don't have apnea or hypopnea, we only have during sleep a CO2 elevation, and then we spoke about hypoventilation during sleep. So this is, of course, in the real life, the apnea and hypopnea does not look exactly as in a graphic, but in this example, we can see some apnea following by desaturation, some long apnea again in the second part of the image, again following by desaturation. This is like when we have also an EEG montage, can we have all the information in one image, let's say in one like here in one slide, we can see the sleep study, the event, the apnea. We can see the paradoxical breathing, and we can also monitorize the CO2 and the saturation in. So it's easy to see in only one image all the information. So at the end, when we have the medical final report of the polysomnography, this is in Romanian, but we have general respiratory breathing in sleep. But if we have a polysomnography, then we can have a specific diagnosis if it is resistance, high resistance in the superior respiratory tract, or if it is a sleep apnea, or if it says hypoventilation, or we have a mix. So there are normal parameters and some criteria to integrate this. And as I showed you before, we can have all this information on polysomnography. Sometimes we have very severe cases, like here. This is a hypnogram. We can see all night in one image. So we can see about on the upper part the sleep stages, and here with red many sleep respiratory events. With red, there are obstructive respiratory events. This is another case which is a lower, mostly hypopnea, and if we can see, most of them are on a REM sleep. So this is a patient, the mother of a patient of 12 years old. I'm not sure that I give the right slide share screen to can hear the mother. I will not come back at this moment, but she can she agreed to have this testimonial, and it is a 12 years old girl with myopathy, Bethlehem myopathy. And the mother described that the child is very violent, have a headache, and very difficulty of learning. So for this patient, she came to us when she already has 12 years old. It was 12 years old, so it's not seeing before with this daytime symptoms very important. So very shortly, Bethlehem myopathy is a disease affecting the skeletal muscles and connective tissue, and is characterized by slowly progressive muscle weakness and joint stiffness. Of course, there is dynamic, may begin before birth, then shortly after birth, we can see a low muscle tone, and then in early childhood, delayed motor skills, and this is probably the moment of the diagnosis. And then the symptoms can, with the muscle weakness and contracture, and then we can see in adulthood the progression of the symptoms. So generally, the disease is characterized with slowly progressive muscle weakness, and the diagnosis we are doing by genetic test, which is available now. The gene is related with the collagen gene. So the diagnosis include the clinical evaluation, sometimes the skin biopsy, muscle MRI, electromyography, genetic test. I will not enter in these details because this is the neurological monitorized and together with the genetic test. And the treatment is mostly symptomatic and supportive. The patient, the children are doing physical therapy, stretching exercise, braces, splints, in order to emphasize and improve, relieve the symptoms, the pain, and improve the quality of life. So coming back now to the quality of life, as we can see, sometimes it's not only related with the muscles and with the motor problems, but sometimes, as in this case, we have a patient where the symptoms was mostly related with aggressiveness. The child has learning difficulties, daytime fatigue. The mother have very hard, it was very hard to wake up the child in the morning, and this is with the agitated sleep, and this is day by day. And for this child and for this mother, this was very, very difficult. So this moment, the patient has a referral from the neurologist for the polysomnography. As you already know, the polysomnography is this investigation when we can see through the montage, different montage, all this information we need regarding the sleep apnea, the respiration, the flow. When we put an electrode, then we have information. And at the end, we read all this information. And in this case, we had not so many, we observed at the polysomnography, not so many apnea. So it was an index of lower than 1. The minimum saturation was 94, so not so low, but the CO2 was elevated. So during the sleep, we could monitorize with the CO2 transcutaneous, and the level was higher than 50. And it also in the morning from blood, we have PCO2 of 65. Yes, and the lower pH. Of course, we did the spirometry and was a low restrictive pattern. So the FEVC was around 50%. So in this case, we didn't have like a typical sleep apnea. We mostly have a hypoventilation, which is the clinical aspects in hypoventilation is with insomnia. Of course, usually it's not, we cannot find all the symptoms, but in this case, we had insomnia, we have frequent arousal, so agitated sleep, a headache, and the lower performance at school, and also with sleepiness. We can also find this hypercapnia not only in children with muscular or neuromuscular disease, but sometimes we can find an intermittent hypercapnia in children with sleep apnea. And this could even be the interaction between hypercapnia and hypoxia is even more important than only in the hypoxia. So this interaction, it's much important as impact. Of course, the patient has the scoliosis, and so together we have to put always together the symptoms and the signs which we observe during the day. In this case, the spirometry was 53%, and the symptoms and the signs and the results of polysomnography, in this case with hypoventilation and the CO2 elevated. And in this case, we decided to start the treatment with during sleep with non-invasive ventilation, means this device which we use to normalize the ventilation. It's help in order to eliminate the events if there are, or if to normalize the CO2. So this is again the mother who explained us the evolution with the BiPAP therapy. She said that the child is much more friendly after a few weeks of treatment. Does she walk much better? It's not so nervous anymore. We repeat the polysomnography with the device, with the BiPAP, and we could see that this is, I mentioned here the settings, and we could see that the CO2 was much lower in the second polysomnography. The CO2 was 45, and also the CO2 in blood which was lower, and the pH was normalized. Of course, that we took, we talk about compliance, and we have this perspective. Does the child or the patient wear the device? Is the mask fit for the children, for the patient? Is it synchronized? Do we have leaks? So the devices usually have this card. We can have a card, we can download it. And in this case, we very rapidly see that the child wear the device more than 4 hours, even 8 hours, 6 hours during the night. So this is a very good compliance from the beginning. So our impression is always that when a child needs and feel the benefits. As Professor Volhurs told us in the morning, that if the child, the patient in general, I think it's the same in adults, feel benefits, they will wear the device. So not only our perception, but it's also the patient and the mother who explains us from their perspective how much differences was done by treating this hyperventilation during sleep. So the conclusion was that, and in conclusion, is that also in this kind of patients, when there is a chronic disease, which basically in this moment does not have a treatment as an etiology, because it's a genetic disease, and maybe not only the genetic disease have treatment at this moment. But we also, it's good to evaluate as a multidisciplinary team to put together the investigation during the day and during the night, in this case, like spirometry and oximetry and the CO2 during the day, but also all the information we can obtain for the sleep time. So this is the symptoms and also the investigations, because the evolution, it's very frequent, progressive, and sometimes we can even detect very early some important modification in this area, like it was in this child, but also in other neuromuscular disease, where we can observe only in REM sleep at the beginning, and after a few years appear in REM and non-REM, and at the end, so again after a few years during wakefulness. So we can provide treatment early and also increase the quality of the life for this patient. In this case, our patient, our girl, it's much better in school. The relation with the mother, it's much improved, and also her mood day by day, she does not have any headache, so basically have a much better quality of life. So as a final conclusion, when we have respiratory breathing disorders in the sleep, and the patient with a neuromuscular disease or restrictive disease, we recommend non-invasive ventilation as a first line of treatment. So this is the end of my presentation, and of course that different is a word that describe all children. So I begin the presentation in English, because we have together our colleagues, international colleagues. Mulțumesc tuturor. Again, to our international speakers for help us to see the effort and to understand what is behind of all the paper and all the conclusion which we have and then we translate in front of the patient. I think we can finish here our second day. From my perspective, it was a full day. I think tomorrow is another very important day, the third day, with many presentations from different area of sleep regarding diagnosis, regarding the physiopathology, regarding the new guidelines. So we are waiting you tomorrow. Vă așteptăm mâine la ora 9:30. If there are any comments din partea organizatorilor, dacă sunt alte informații sau...
Vă așteptăm mâine. Vă rugăm să vă verificați mail-urile pentru că vă vom trimite linkurile pentru mâine. Sunt aceleași, dar le vom trimite într-un nou mail. Vă așteptăm și sperăm să ne fiți alături până la sfârșitul conferinței.
Dacă mai sunt alte întrebări, puteți să le trimiteți sau să vă gândiți și noi le vom trimite speakerilor care au generozitatea să ne răspundă, chiar și după ce se închide evenimentul astăzi. Mulțumim încă o dată!
Ne revedem mâine la 9:30.
La revedere!
La revedere!
Salut! Ea este apnea. Nu știe să facă prea multe. Ce știe să facă cel mai bine este să ne tulbure somnul. Da, poate fi chiar enervantă. Haideți să vă explic ce este apnea de fapt. Apnea în somn este o condiție în care mușchii din spatele și din părțile laterale ale gâtului se relaxează atât de tare încât atunci când dormi, respirația este blocată pentru câteva momente. Când se întâmplă acest lucru, creierul observă o lipsă de oxigen în sânge și ne trezește suficient pentru ca respirația să revină. Apoi intrăm din nou într-un somn adânc, iar ciclul continuă, fără ca noi să observăm această succesiune. Așa cum spuneam, totul se întâmplă în somn. Chiar și sfărăitul poate semnaliza existența apneei. Dacă un copil sau un adult sfărăie mai mult de câteva săptămâni sau luni la rând, înseamnă că nu respiră bine în timpul somnului. Toate acestea pot duce la un nivel scăzut de oxigen în sânge și niveluri ridicate de dioxid de carbon în somn. Pentru a pune în evidență apnea din timpul somnului, se pot realiza analize specifice, numite poligrafie sau polisomnografie. Despre acestea și despre posibilități de tratament vom povesti mai multe în următorul episod al animației. Până atunci, puteți afla mai multe informații pe pagina noastră de Facebook, Asociația pentru tulburările de somn la copii și adolescenți. Împreună putem promova un stil de viață sănătos.